again, everyone, and we're going to start in next 1 minute. We're going to live. So, good morning, everyone, and it's a great pleasure to welcome you all for the day two of the workshops which we're doing for the fifth lung cancer update, and this is done under the aegis of Cancer Research and Strategy Foundation. Uh, we start the day, and it's a pleasure to welcome Dr. Akshay Karpe sir, who is the president for Cancer Research and Research Foundation, and also a senior medical oncologist from Mumbai. Good morning, everyone, and I head over the mic to Dr. Akshay Karpe sir. Over to you, sir.
Uh, Hello everyone. Thank you, Mr. Tarun Mathur and Horizon Conference team, basically for arranging this meeting. And
Hi, my name is Satyanam Das.
yeah, under the aegis of CRSF.
Here are my disclosures. My primary disclosure
Yeah. So
with
under the
regards
aegis
to a
of
roadmap for the
CRSF,
talk, I'd
we
like to
always
start
conduct
with
these
talking
two
about the
sessions.
current
One is a
targets.
lung masterclass, which is dedicated to the training of medical students who are undergoing oncology or who are oncology aspirants, which is usually in the month of August, September. While this is lung update, which is usually held for the consultants. And in this, we actually try to cover all possible aspects, whether it's a pathology, whether it's a nuclear medicine, whether it's a radiation, whether it's a clinical side, palliative, geriatric care. So, whole lot of aspects we are going to cover. So, we had workshops which were yesterday also, tomorrow also we are going to have workshop. So on the various aspects of the cancer. So cancer basically is a comprehensive care, and under the aegis of CRSF, basically whenever we conduct these conferences, we try to do these conferences which are very much site specific, so that most of the information which has been, there are updates which are there, which are very difficult to handle by a single person. So all these are covered during this meeting. So in this, we are having a nuclear medicine workshop, and the convener for this is Dr. Ameya Puranik. Dr. Ameya Puranik is an associate professor of nuclear medicine and prestigious Tata Memorial Hospital. He's a very dear colleague of mine, and he has actually arranged a very quiet, comprehensive program. And through this, Dr. Ameya Puranik will highlight various aspects of nuclear medicines in the management, in the diagnosis, and even in the treatment of the lung cancer patients. So I will hand over to Dr. Ameya Puranik for the further proceedings. Over to Dr. Ameya Puranik.
Good morning, everyone. Welcome those who are online as well as those who are present in the audience. At the outset, I would like to thank CRSF for giving me the opportunity to organize this workshop, as well as I am thankful to Sunrise Oncology and Institute of Pulmonology for conducting this hybrid webinar. Well, our webinar focuses on the emerging field of theranostics, where we'll be dealing with different radionuclides, particularly targeting neuroendocrine tumors, prostate cancer, as well as the newer emerging agents. We have elite faculty from across the globe, as well as from India, who will be dealing in these subjects. Without further ado, I would like to start the session. Our first talk will be given by Dr. Satya Das. Dr. Satya Das is Assistant Professor of Medicine in the Department of Medicine and Division of Hemato-Oncology and GI Oncology at Vanderbilt Ingram Cancer Center in United States. His research interests are in the realm of gastrointestinal cancer with focus on neuroendocrine tumors and early drug development. His background in drug development and translational science stems from completing his master's in clinical investigation program at Vanderbilt, and currently he focuses on caring patients with advanced GI malignancies with prime focus on neuroendocrine tumors and targets for neuroendocrine tumors. So we have given him an apt talk, which is emerging targets for very differentiated neuroendocrine tumors, choices and selection. Let's begin the session with the first talk from Dr. Satya Das. Thank you.
Satyananu Das. I'm a GI medical oncologist at Vanderbilt Ingram Cancer Center. I help lead our neuroendocrine tumor program, and it is my real pleasure to be giving this talk titled Emerging Targets for Well-Differentiated Neuroendocrine Tumors, Choices and Selection. I'd like to thank the organizing committee for this opportunity today. Here are my disclosures. My primary disclosure is that there will be discussion of off-label therapeutics during this talk. With regards to a roadmap for the talk, I'd like to start with talking about the current targets in neuroendocrine tumors, how to choose among available treatment options in the clinics, novel targets in neuroendocrine tumors, combination therapies, and ongoing questions for the field, with the latter categories focused on radionuclide therapy, given the theranostic focus of this workshop. So what are the targets in neuroendocrine tumors? There are a number of proteins both on the surface and cascading pathways that are currently targeted in the clinic. Some of the main players here include somatostatin receptor 2, which is targeted by agonists such as the somatostatin analogs, as well as peptide receptor radionuclide therapy. Other key targets include the mTOR pathway, which is downstream of PI3 and AKT and plays critical roles in neuroendocrine tumor growth and oncogenesis. And we have upstream receptor pathways such as vascular endothelial growth factor, which are targeted by agents such as sunitinib and several of the other tyrosine kinase inhibitors that we will touch on in this talk. With regards to the agent types we'll be discussing, we will primarily be focusing our efforts on radionuclide therapy. However, we will touch on anti-vascular endothelial growth factor as well as non-VEGF receptor pathway inhibitors in brief as well. So focusing on the radionuclides that are currently being tested, both on trial and in the clinic, we start first with our basic schematic of PRRT, which we all know and are familiar with. The concept being a peptide is linked to a radionuclide. The radionuclide that is currently approved and has garnered regulatory licensure in many countries across the world is 177 lutetium. However, other beta emitters such as Y90 have been tested and originally were actually trialed first in some instances. Beyond beta emitters, there's a lot of excitement in the field about alpha emitters, compounds such as actinium-225, which has a long history of trials and use in India, as well as 212-lead and 213-bismuth are some of the other agents that are being tested currently. With regards to PRRT types that use different peptides, though most PRRTs currently utilize somatostatin receptor agonists, somatostatin receptor antagonists have also been tested. Sadoreotide tetraxetan is an agent formerly known as JR11, which has some small phase 2 data, though there have been some concerns about myelosuppression with that agent. So what about the factors that influence our treatment selection? I think the primary factors that we utilize in the clinic include primary tumor origin and somatostatin receptor 2 expression. As we all know, somatostatin receptor 2 expression is now cataloged through the utilization of dotatate imaging, whether that's dotatate PET or dotatate MRIs. The uptake of that has really been transformative. So here we have a patient with a pancreatic neuroendocrine tumor with relatively low volume disease that's dotatate avid. In these instances in which a patient needs treatment, we usually start with a somatostatin analog, whether that's octreotide or lanreotide, based on patient body habitus and tolerance. Upon progression, we can think about things such as capecitabine plus temozolomide or PRRT with lutetium. And in no particular order in the later line setting, we think about agents such as everolimus and sunitinib, which have garnered regulatory approval for pancreatic NET patients, or some of the more novel tyrosine kinase inhibitors such as cabozantinib, surufatinib, and lenvatinib. Notably, all but surufatinib are off-label use, surufatinib the exception being in China, where it is approved for the treatment of patients with both refractory pancreatic and extrapancreatic neuroendocrine tumors. However, this approval is still being weighed in the United States. With regards to a patient with a midgut primary, again, we have a patient with a midgut NET with low volume somatostatin receptor avid disease. We again think about the somatostatin analogs being our first line of therapy. And upon progression, it's usually a choice of PRRT with lutetium or everolimus. And typically upon progression, we think about VEGF TKIs in the clinical trial setting, whether that's cabozantinib, lenvatinib, and hopefully soon surufatinib to garner approval. Disease bulk also plays a very important role. So here we have a patient with a pancreatic neuroendocrine tumor with an extensive volume of disease encompassing much of the liver. In this case, I typically think about a debulking strategy. Until now, capecitabine plus temozolomide carries the most cytoreductive potential among all available therapies, and thus utilizing this as an initial therapy. In post-cytoreduction, I think there's a lot of different angles in which one can go, perhaps utilizing a somatostatin analog, and thereafter, only upon progression, thinking about things like PRRT. There is data for FOLFOX-based chemotherapy in patients with pancreatic neuroendocrine tumors, which tend to be the most chemosensitive of all of our neuroendocrine tumors. And if cytoreduction in a more biologically indolent behavior is achieved, one could then think about the tyrosine kinase inhibitors that are utilized in non-bulky NETs as well. Other factors that influence treatment selection include tumor size. This is some very interesting post-hoc data from the NETTER-1 trial. So in the post-hoc analysis from NETTER-1, several features were looked at as to whether they influence PRRT responsiveness or not. And one of the factors was the presence of a large tumor, defined in the study as a tumor that was greater than 3 centimeters in size. And what was quite striking is that patients in the lutetium-treated arm, pointed in blue in the Kaplan-Meier curve, had a strikingly different PFS based on the presence of even a single large lesion. So patients without a single large lesion had a 2-year progression-free survival rate of 90%, whereas patients with even one tumor of 3 centimeters or greater had a 2-year progression-free survival of 55%. And so tumor bulk and individually bulky lesions has to be a thought process when we think about PRRT currently with lutetium, and other strategies in which we can perhaps remove bulky tumors or better optimize their management to increase the effectiveness of PRRT. Other factors include tumor grade. So on the left-hand side, we have Kaplan-Meier curves from a retrospective analysis in pancreatic NETs And we see that all of these patients were treated with lutetium dotatate. And we see that patients with the Ki-67 greater than 5% in the green line had reduced PFS that was strikingly different from patients with a Ki-67 of equal to or less than 5%. And I know Dr. Mitra will be talking extensively about the role of PRRT in well-differentiated grade 3 neuroendocrine neoplasms, but I just wanted to also raise the point that grade 3 neuroendocrine neoplasms treated with PRRT have a much shorter progression-free survival compared to grade 1 and grade 2 tumors. So perhaps in the context of dealing with patients with well-differentiated grade 3 neuroendocrine neoplasms, PRRT may be utilized as a treatment, but perhaps not in an earlier setting, or perhaps not first. So how to choose among existing therapy? Several tools, both clinical and biomarker-based, have been developed. One of the tools that I've been fortunate to be a part of the development for is the clinical score. So this is a score that's comprised of 5 categories which have been vetted and scored through a multidisciplinary tumor board evaluation. This is a score that was prospectively developed and has now been validated in external cohorts. This manuscript should be coming soon, and we are hopeful to actually incorporate the score as well into prospective studies to actually see if, beyond prognostic implications, it carries predictive implications. But the 5 constituents of this score include patient symptoms, tumor bulk and critical organs, non-PRRT treatments available based upon primary tumor origin, presence of peritoneal carcinomatosis, and previous systemic therapies received. So this is some of the validation data from the score. On the left is a Kaplan-Meier curve of progression-free survival. On the right is a Kaplan-Meier curve for overall survival. So the green line refers to patients with who received 3 to 4 doses of PRRT. The solid green line refers to patients with a clinical score of 4 or less, which was the cut point in our data. And we see a 3-year progression-free survival of close to 75%. The dashed green line refers to patients who received 3 to 4 doses of PRRT, but who had a clinical score greater than 4. And we see a 3-year progression-free survival of much, much lower, less than 10%. Quite interestingly in our data, patients who only got 1 to 2 doses of PRRT in the red, solid, and dashed lines respectively had the lowest progression-free survival benefit from PRRT. And we can see that with regards to overall survival, a similar trend was observed based upon PRRT's utilization. So based upon this data, there is a suggestion that the utilization of PRRT when patients are less pretreated and have lower disease burdens may influence the effectiveness of the therapy. Other factors such as the biomarker tool called the PRRT predictive quotient, or the PPQ, is a biomarker which has actually been validated in multiple external cohorts. This is a combined biomarker comprised of mRNA gene transcripts as well as IHC-based Ki-67 grading. And based on the readouts, patients' tumors are assigned basically the score of a positive PRRT responder or a negative PRRT non-responder. This is the validation data for the PPQ. Looking at the 3 cohorts, so in the cohort from Mediola, we see patients with a positive PPQ had a PFS with lutetium PRRT that was not reached, and a median PFS in the PPQ negative group of only 11 months. In the Bad-Burka cohort, we see a very similar median PFS not being reached in the PPQ positive patients, whereas in the PPQ negative patients, median PFS was 14 months. And in the Rotterdam data, we see a median PFS of not reached in the PPQ positive patients, and median PFS of about 10 months in the PPQ negative patients. Quite interestingly, patients who were treated in the controls cohorts of each of these validation sets, being treated with either octreotide or on observation, there was no correlation between PPQ positivity and response, suggesting that this may be a predictive biomarker for patients receiving PRRT. However, in clinic, the realistic implication is that even PPQ negative patients seem to derive some benefit from PRRT. And so the question becomes, even if a patient is PPQ negative with adequate somatostatin receptor expression, would one withhold PRRT? And at this point, that is, given the still lack of relative availability of options for patients with NETs, that would not influence our choice. However, this is something that in the future, as our treatments expand, may become more meaningful. So how else can we choose amongst existing therapies? So there are a number of very interesting sequencing studies that are ongoing that in the next several years will give us hints of how we perhaps should be optimally employing these therapies. The first of these studies is the NETTER-2 trial, which is a randomized phase 3 global study. In this study, patients with more biologically aggressive GEP-NETs with Ki-67 indices of 10 to 55% will be randomized to 4 treatments of lutetium dotatate with accompanying octreotide or a higher dose of octreotide monthly. The primary endpoint of this study is progression-free survival, with key secondary endpoints of overall survival and response rate. The important questions, in my eyes, being addressed by this trial is that is PRRT a possible first-line treatment for patients with more aggressive G2, G3 GEP-NETs? And perhaps more importantly, because patients in the control arm are going to conceivably getting PRRT upon progression, is that the OS endpoint. And so is giving PRRT initially more effective than giving PRRT upon progression? Another sequencing study that's ongoing in France is the Oclor-Random study. This is a randomized phase 2 study in second-line patients with well-differentiated pancreatic NETs. Patients are randomized here to 4 cycles of lutetium dotatate or 37.5 milligrams of sunitinib daily, which is the approved dose. The primary endpoint of the study is 12-month progression-free survival, with the key secondary endpoints of best overall response and overall survival. The important questions that this trial is addressing is that should PRRT be sequenced ahead of sunitinib in the second-line setting in patients with pancreatic NETs? And what is the effectiveness of PRRT alone, administered in the absence of concomitant somatostatin analog, which still remains a bit of a controversial topic, given that no prospective data for PRRT alone in large settings exists. Another study that's ongoing in an unmet need population of bronchial NETs is NCT 5739. This is a randomized phase 2 study in the United States which just recently began accrual. In this study, patients with somatostatin receptor positive well-differentiated bronchial NETs are randomized to 4 cycles of lutetium dotatate or 10 milligrams of everolimus daily. The primary endpoint of the study is progression-free survival, with key secondary endpoints of overall survival, AEs, and response rate. The important questions being addressed by this trial is what is the effectiveness of PRRT in patients with bronchial NETs? Our hope is that if this study is positive, that this will lead to regulatory licensure for bronchial NETs in the United States and hopefully across the rest of the world thereafter as well. And the second question is that should PRRT be sequenced ahead of everolimus in patients with bronchial NETs? Because again, upon progression, it is assumed that patients in the everolimus arm will also be receiving lutetium dotatate. With regards to some of the novel targets in neuroendocrine tumors, one of the major areas of looking at combination therapies with PRRT are DNA damage repair pathways. As we know, PRRT with lutetium dotatate elicits single-strand DNA breaks, and in theory, adding agents which can perpetuate single-strand breaks into double-strand breaks should increase the effectiveness of PRRT, thus the motivation for these studies. These are all early phase studies being conducted through the Experimental Trials Network of the National Cancer Institute. The first is the ribonucleotide reductase inhibitor triapine plus lutetium dotatate. This is a study that is accruing very well in patients with GEP-NETs. The second is a study of the PARP inhibitor olaparib plus lutetium dotatate in patients with GEP-NETs. This has not yet opened to accrual, but should be doing so quite soon. And the third study is the DNA PK inhibitor peposertib in combination with lutetium dotatate. And here, DNA PK has well-established data in combination with ionizing radiation to create more double-strand breaks as the motivation for this concept. And so this is a single-arm phase 1 study in patients with GEP-NETs, which has actually started to accrue. So the important questions that are being addressed by these trials are, one, can DNA damage repair inhibitors safely be added to PRRT? And second, can they elicit greater cytoreduction than lutetium dotatate alone, whose response rate is quite modest relative to some of our other therapies? Another novel target is alpha radionuclides. So this is an ongoing phase 2 study being led by Dr. Del Passand in Houston, utilizing lead dotamtate in SSTR-positive neuroendocrine tumor patients. The patients here are treated with 3 doses of lead dotamtate with a primary endpoint of maximum tolerated dose and defining the dose-limiting toxicity profile and the key secondary endpoints as listed. The important questions being addressed by this study is that, is lead dotamtate safe to administer? And specifically, what is the activity of alpha-emitting radionuclides in PRRT-naive patients? Another alpha emitter that's actually been tested and has well-validated data from prospective cohort through the AIMS group in India is actinium-225. This was a cohort study that was presented by Drs. Ball and Balal and has been published subsequently. In this study, patients with treatment post-lutetium dotatate, either with stable disease or refractory disease, were then treated with actinium-225. And what we can see is that in patients who are refractory to lutetium dotatate on the left, the response rate with actinium-225 was more than 40%. And in patients with a best response of stable disease to lutetium dotatate, actinium-225 produced a response rate of more than 60%. The patient images on the right are striking dotatate images from a patient with a rectal neuroendocrine tumor with extensive bony and liver involvement from the disease. And thereafter, after 2 cycles of actinium dotatate, we see a complete response. So the important questions that were addressed by this prospective cohort analysis is that, should alpha-emitting radionuclides be reserved for patients with either refractory disease or suboptimal responses to lutetium dotatate? And there are phase 3 studies that are in development looking at actinium as well as other alpha emitters post-lutetium dotatate that are currently in development. So what about non-radionuclides targeting somatostatin receptor 2? So one of the compounds that was recently tested is PEN-221, which is an antibody-drug conjugate conjugating DM1 or maytansine, a microtubule inhibitor, to a somatostatin receptor targeting ligand. This was data that was phase 2 data in mid-gut-net patients that was presented by Dan Halperin at NANETS as well as ASCO this year. And what we can see is that in patients who had a prior 2 lines of therapy, this compound produced a median progression-free survival of 9 months. There were 2 cohorts, PRRT naive and PRRT recurrent patients or progressive patients, and the numbers were too small to make definitive conclusions in this setting. But based on this activity and the overall tolerability of the agent, a subsequent randomized study is being planned in patients with mid-gut-net. Another somatostatin receptor targeting raw non-radionuclide therapy is tidutamab, which is a BiTE antibody which targets CD3 on the cytotoxic T cells and somatostatin receptor 2, with the premise that this agent may be able to bring in effector T cells into the tumor microenvironment for NETs. As we know, immunotherapy with checkpoint inhibitors has not yet been effective in this space, and so the thought is to see if this agent could be utilized. As with many BiTE antibodies targeting immune effector cells, cytokine release syndrome is a concern. However, in this study, 41% of patients experienced cytokine release syndrome, but in most cases it was grade 1 or grade 2. With regards to response, these patients were heavily pretreated, receiving a median of 4 prior lines of therapy, The investigators rather saw no responses. However, stable disease was observed, and durable responses were also observed in this setting. So, while this phase 1 study is still ongoing, it appears that safety has been established, but this agent as a monotherapy drug may not hold as much promise as perhaps as in combination with checkpoint inhibitors, which studies for this are in current development as well. So with regards to combination therapies to perhaps overcome disease heterogeneity, we know that lutetium-177 is a medium energy beta emitter. But what about combinations with a heavier energy beta emitter such as Y90? Several prospective approaches have explored this. The first was a phase 2 parallel enrolling cohort analysis looking at patients with primarily midgut and foregut NETs who were treated with either lutetium and Y90 in tandem or Y90 alone. And though this was not powered to be a comparative study, we see that the overall survival was significantly longer in patients treated with the tandem approach. A subsequent study, primarily in GEP-NET patients, also explored the utility of tandem therapy with Y90 and PRRT, and we see again significant improvements in progression-free survival and overall survival than anticipated at that time with either therapy alone. So based upon some of this phase 2 data, there is a ongoing non-randomized phase 2 parallel assignment study in patients with GEP-NETs, bronchial NETs, and other NETs called the POL-NETs trial. In this trial, patients with somatostatin receptor positive NETs are treated with up to 4 cycles of Y90, and thereafter patients are either treated with 4 cycles of lutetium dotatate or 4 cycles of a 50-50 mixture of lutetium dotatate plus Y90. The main question that the study is seeking to ask is that does the addition of the more energetic beta emitter to lutetium dotatate increase the effectiveness as measured by progression-free survival, as well as response rate and overall survival experienced by patients? Radionuclide therapy plus chemotherapy is also being looked at. The CONTROL-NET study was a parallel randomized phase 2 study in pancreas NETs and midgut NETs. Patients with pancreatic NETs were randomized in a 2-to-1 fashion to PRRT plus CAP-10 or CAP-10. Patients with midgut NETs were randomized in a 2-to-1 fashion to PRRT plus CAP-10 versus PRRT. The median, the primary endpoints in the pancreatic NET cohort was 12-month PFS, and the midgut NET cohort was 15-month PFS. This is data that was presented from the Australian group at GI ASCO, and what we see is in pancreatic NETs, the combination of CAP-10 plus PRRT elicited a greater 12-month PFS rate and a much deeper objective response rate with no additive toxicity that was observed. However, in patients with midgut NETs, there was no difference in 15-month progression-free survival. However, the grade 3-4 adverse events were much more significant in this setting. So perhaps in pancreatic NETs, there may be more of a role for combined therapy with CAP-10 plus PRRT. And in thinking about the patients that may benefit from chemotherapy plus radionuclide therapy, what about patients with tumors with FDG avidity? It's well known that FDG avidity is a poor prognostic biomarker in patients with well-differentiated NETs, and furthermore in patients with well-differentiated NETs treated with PRRT. From the Kaplan-Meier curve on the right, predominantly in a pancreatic NET cohort, patients who were treated with lutetium dotatate experienced a marked reduction in progression-free survival compared to patients with FDG negative disease or non-avid disease. And this is well validated by the NET-PET score, which many thought leaders around the world are now proposing that we use for perhaps even lower grade and well-differentiated patients to truly assess what extent of disease is FDG avid versus what degree is FDG negative. Based on the suggestion that FDG positive disease patients have more aggressive disease, a cohort study looking at capecitabine plus lutetium dotatate was initiated in patients with FDG positive GEP-NETs. In this study, most patients had pancreatic neuroendocrine tumors, and what was seen is that the objective response rate was 30%, disease control rate was close to 90%, and the median progression-free survival was 31.4 months, which is longer than the historical control data expected with PRRT alone. And we see that both pancreatic NETs and GI NET patients experienced meaningful progression-free survival benefit, also pointing to perhaps another cohort of patients, the FDG-avid patients, in which radionuclide therapy plus chemotherapy may play a role. So where may immunotherapy plus radionuclide therapy play a role? Though single-agent checkpoint inhibitors have had disappointing activity in patients with well-differentiated NETs, there has been suggestions of activity in higher Ki67 neuroendocrine tumors, so the G3 population or atypical lung NETs. And there is preclinical work that treatment with lutetium dotatate can increase the infiltration of antigen-presenting cells and NK cells, which is observed on the diagram on the right. And based upon this work, an ongoing study, NCT 7948, is exploring whether pembrolizumab plus liver-directed therapy or in combination with lutetium dotatate carries activity. This is a non-randomized parallel assignment study. There are, however, other randomized studies in development exploring pembrolizumab plus PRRT in patients with G2 and G3 NETs. So at this point, it remains undefined which patients should be considered for combinatorial therapy. The patients in whom this approach may be most biologically plausible include patients with bulky disease, patients with higher grade tumors, patients with FDG-avid tumors, patients with pancreatic NETs. Several novel randomized trials with lutetium dotatate and lutetium dotatate combinations are currently in development, and some of the most exciting include DNA damage repair inhibitor, radiosensitizers, and immunotherapy combinations. So some of my parting thoughts include emerging questions for the field. The largest one that several trials are poised to answer is that where should lutetium dotatate be positioned relative to other available therapies? How should we define the optimal candidates for lutetium dotatate? Is it through a biomarker? Is it through things like the clinical score? Furthermore, some of the novel VEGF receptor tyrosine kinase inhibitors being developed, where do they fit in? And where do potential combinations of VEGF TKIs fit in the landscape? Where should alpha radionuclide therapy be positioned? Should it only be after beta-emitting therapy, or should it be used before? What about the hematologic long-term toxicities of potential combination approaches with lutetium dotatate? Will the risk of MDS be increased? And how long do we have to follow up to truly assess this risk? I think another interesting question is that will other somatostatin receptor targeting approaches, such as immunotherapy and some of the chemotherapy conjugates that I've discussed, will they carry the same activity as targeted radionuclide therapy has? Some of the early suggestions may point to the fact that they may be less effective, but this remains an active question. So with that, I'll close. I'll be happy to take any further questions. Thank you so much for your kind attention.
Thank you, Dr. Satya. It was a wonderful talk, and you have covered almost all aspects of neuroendocrine tumors, the early phase 1 studies, as well as the combination therapies. I don't think we have any questions, but from my side, I would like to ask a couple of questions. Now, when we sit in the NET clinic, neuroendocrine tumor clinic, we have currently only 2 or 3 options in case of grade 2 NETs, that is capecitabine temozolomide or sunitinib in addition to PRRT. So, what is your experience when you are actually dealing with patients as far as the combination therapies are concerned? What all have you practically used? And apart from the trials that you have quoted, what is your practical clinical experience in using combination therapies?
Yeah, thanks for your question, Dr. Pranik, and it's really a pleasure to be here. I think as you hit it on the head, I think practically speaking, off-label, we still use single-agent therapies. So primarily for patients with pancreatic NETs with bulkier disease, I usually start with capecitabine plus temozolomide. And so once we're able to hopefully debulk these patients due to their chemosensitivity, we can then think about perhaps more indolent therapies, things like the somatostatin, kind of more the sequencing of therapies, usually positioning our more cytoreductive options earlier for patients with bulkier disease or perhaps more aggressive disease.
Okay, thank you. And you also quoted
Yeah, so it's a fantastic question as well. So the PPQ we do not yet routinely use. I think the big thing that folks around the world and country are still trying to think about does it actually change management? Are we still going to withhold PRT from a patient that's PPQ negative? And as you hit on, because we still don't have as many options, I don't think that would influence our choice yet. Now, the NET test is quite interesting. We are using it in select cases. I've used it more after a curative resection, when there may be sort of an equivocal imaging finding. The NET test may point us to perhaps looking at a different type of scan, such as utilizing a dotatate scan in addition to CT. But I haven't yet routinely used the NET test as a marker of response with tumor. So it'll be fascinating to see how the NET test correlates prospectively with response to PR.
Thank you. One final question. Apart from FDG and dotatate PET-CT, any particular biomarkers which you...
So a little bit of a controversial question in that I personally actually don't use chromograninate just because of the nature of the fluctuations that can be seen due to both medications, inflammation, and other disease conditions. For patients with functional midgut neuroendocrine tumors, I typically use a plasma 5-HIA if they have carcinoid syndrome. That's not my only choice of a biomarker. However, I feel that correlates. So usually the plasma 5-HIA is the biomarker that I use in patients with carcinoid syndrome. But apart from that, it's really based upon imaging and clinical symptoms that I rely on at this point.
Great. Thank you, Dr. Satya. Your talk was indeed wonderful, and you have thrown novel insights into the management of neuroendocrine tumors, especially from the point of view of combination therapy. Thank you for giving a wonderful talk. Well, we now grade 3 into the very differentiated and poorly differentiated neuroendocrine neoplasms, and hence PRRT has come in as an option in grade 3 tumors as well. So we have Dr. Eric Mitra, who is a professor in diagnostic radiology and chief of nuclear medicine and molecular imaging at Oregon Health and Science University in Oregon, who is going to talk on PRRT in grade 3 neuroendocrine neoplasms. Dr. Mitra is also a part of the working group of NANETS and is a management of NET is concerned. Over to Dr. Mitra. Thank you.
Good morning, everyone. My name is Dr. Eric Mitra from Oregon Health and Science University in Portland, Oregon. I want to thank the organizers of this session for inviting me to give this talk. The subject is PRRT in G3-NENs. I don't have any relevant disclosures to this talk. Some general disclosures are listed below. The outline is as follows. What I'll be presenting is primarily the work of the North American Neuroendocrine Tumor Society NANETS G3 working group. This group has been in existence for approximately 1 year now, and we're getting very close to finalizing our results. And so much of the content is coming from this working group. But specifically, I'll discuss some of the aspects related to histology, and then discuss imaging, and then finally focus on the main topic, which is PRRT. So a little bit more background on this working group from NANETS related to G3. It's led by Dr. Jennifer Eads, and there are a variety of other physicians that are involved representing a variety of different specialties. You can see some of the names listed there. And as mentioned, we are very near completion, so this should be published in the very near future, and you can look forward to that. With regard to pathology, these are the classification from the World Health Organization in 2019 was the latest update. And you're probably relatively familiar with the fact that we grade these tumors based on the Ki67 value listed on the right or the mitotic rate. And for the purpose of this talk, when we're talking about high-grade malignancy, we are in this area here, which can be further differentiated based on histology between well-differentiated and poorly differentiated categories, all with the same Ki67 and mitotic rate. Some other numbers to keep in mind are listed below. So one is this differentiation between well-differentiated and poorly differentiated is primarily a histologic classification, but many people use a Ki67 value of 55%, and you'll see that throughout this talk, including in clinical trials. Also keep in mind that many patients do have a heterogeneous disease. So although one biopsy might show one specific grade, the patient may in fact have a variety of grades of tumor. And lastly is that patients can develop an initial type of grade, and then subsequently it progresses to a higher grade called grade progression. And that's also something to keep in mind if you're dealing with a biopsy specimen that may be older. With regard to conventional imaging, all the different modalities listed here certainly have a role. Ultrasound is, of course, limited by what can be accessed by the transducer, but it's particularly useful, for instance, for ultrasound-guided biopsies. CT definitely forms the cornerstone of imaging of neuroendocrine tumors, and it's important to keep in mind that you should always use multi-phase contrast-enhanced scans because some tumors are hypervascular, whereas others are not. And so looking at the arterial phase as well as the portal venous phase is important for identifying all of the tumors within the body. And MRI also has a very important role, but primarily for liver and pancreas. It doesn't do as well for the rest of the abdomen or the mesentery, and equally for the lungs. And even for the liver and pancreas, it's important to try and use multi-phase contrast-enhanced scans. Even better would be to use a hepatocyte-specific agent such as Eovist, because that really helps identify the lesions with the greatest amount of accuracy, especially when looking at size differences between different MRI scans. Whichever modality is used, such as CT or MRI, it's important to try and continue that same modality for the future so that the scans are truly comparable. We often have patients coming from community hospitals where one modality is alternated between the other, and that's very difficult to evaluate progression in that scenario. For molecular imaging, there is, of course, a variety of different types of modalities that can be used, shown here. This is, of course, US specific, so there might be some variances that are present throughout the world and in India. The first four that are listed there are, of course, examples of somatostatin receptor imaging, whereas the bottom four that are listed are examples of PET imaging. So if you use a combination of somatostatin receptor and PET imaging, I've highlighted the three radiopharmaceuticals that are most commonly used. Within the US, it's quite exchangeable between gallium-68 and copper-64 dotatate, I would say. And we don't really have a strong preference between one versus the other. They have individual pros and cons between them. And then FDG is primarily used for higher grade tumors. So let me show that more specifically here in this publication from Michael Hoffman in Australia, showing that the same patient, as mentioned before, can have heterogeneous disease. And so for patients with lower grade tumors, those that are below Ki67 almost always express somatostatin receptors and are therefore better evaluated with dotatate, whereas those that express higher grade tumors, typically over Ki67 of 20%, will lose somatostatin receptor expression but show glucose uptake with FDG. And so really in this range of mid-grade tumors, you might need to actually evaluate the patient both with a dotatate scan and FDG scan, and as the Ki67 gets higher, then you would switch mostly to FDG. So this can be depicted schematically as follows. Below Ki67 of 10%, primarily only a dotatate scan is needed, and above 55%, only an FDG scan is needed, but many people would advocate that within 10 to 55%, using both modalities for the complete evaluation of the heterogeneous tumors are what is most useful. This has been taken to the point of having a different grading scale based on both somatostatin receptor expression and FDG expression. And if you look at the categories of P1 through P4, in this area, there is variable expression of both of the radiopharmaceuticals. And further, what was shown in this particular article is that this relative expression between the two radiopharmaceuticals can actually be used to prognosticate the disease for the patient. So that can potentially be very useful, although this is something that still is being fully evaluated. Okay, so with that background in mind, then let's jump into the main topic, which is PRRT in this category of high-grade G3 neuroendocrine neoplasia. So the first thing is, as most people are likely familiar, lutetium dotatate was FDA approved in 2018, and it is only indicated for low-grade or intermediate-grade gastroenteropancreatic neuroendocrine tumors. So anything outside of that, such as a different subtype, would be considered off-label, and certainly G3 would fall within that area as well. However, having said that, there is some preliminary data that PRRT does appear to be promising for G3 NENs, and there are several ongoing, relatively large trials. The two largest ones that are currently ongoing are the NETTER-2 trial, sponsored by AAA Novartis, and then the COMPOSE trial, which is still in the early phases, which is sponsored by ITM. Both of those are looking at the group of well-differentiated G2 and G3 neuroendocrine tumors. And there's also a fair amount of work that's being done in terms of combination therapies, such as capecitabine or PARP inhibitors, because they could potentially accentuate the utility of the radiation from PRRT, or in the case of PARP inhibitors, work in the same way in terms of creating DNA damage that the radiation does. So there are several ongoing combination therapy trials as well. In either case, for this area of G3 NENs, again, somatostatin receptor imaging is critical for eligibility selection, because if there isn't sufficient somatostatin receptor expression, then it certainly wouldn't be a good candidate for that therapy. But it's also potentially useful, again, to evaluate with FDG as well for the prognosticability, and to ensure that truly all the tumors that are being seen by anatomic imaging and by FDG also show somatostatin receptor expression. You wouldn't know if there are other areas which don't show sufficient somatostatin receptor expression unless you do all of the other types of imaging. And what appears to be, based on this preliminary data, is that there is a limited role for poorly differentiated G3 or the neuroendocrine carcinomas. But again, we'll see some information here. So let's look at some of the retrospective data that's been published so far, because again, the prospective trials that I mentioned are currently ongoing and won't be published for a few years. So this is a relatively small study from the Australian group looking at 28 patients with a variety of different grades of tumor. You can see that they also had a variety of different subtypes of disease in terms of their primary, and many of these patients also did actually have FDG-avid disease as well. So they were treated with the lutetium-177, and the overall median progression-free survival was 9 months. However, there was a big difference between those patients who had a Ki67 of less than 55% versus those who had higher than 55%. So you can see that the group that had less than 55% had a median PFS of 12 months versus those that had a Ki67 of greater than 55%, which was only 4 months. So a big difference between those two groups. And it should also be pointed out that there was relatively limited toxicity across all these patients. Grade 3 or 4 lymphopenia or thrombocytopenia only occurred in a very small number of patients, and there was no renal or liver toxicity noted whatsoever. A slightly larger group of patients, 69, from Dr. Baum's research group in Germany. Here, again, a variety of different subtypes of tumors, and they did have both patients with well-differentiated and poorly differentiated histology, and actually the results are very similar to what we just saw from the Australian publication, which is that the median progression-free survival was 11 months for those patients with a Ki67 less than 55%, and only 4 months for those patients with a Ki67 of higher than 55%. This particular paper also looked at the role of imaging and whether or not you could prognosticate using both FDG scans and the somatostatin receptor PET scans, and they did find that the higher the uptake on somatostatin receptor, the better the outcome was. The higher the uptake on the FDG scan, the worse the outcome was, which is now something I feel that is relatively well known in our field, but the specific cutoffs and how we use that information to decide the therapy still is being evaluated, but at least we generally have that understanding. And this paper also showed the same thing in terms of toxicity. There was very limited significant toxicity in terms of hematologic function, and there was no decline in renal or hepatotoxicity seen. This was an interesting patient within that group from Dr. Baum, this particular patient was treated with up to 10 cycles of lutetium dotatate over many, many years. And you can see that they initially had a very good response and had a stable period without evidence of disease for many years. And then when the patient recovered, they were treated again with multiple cycles of lutetium dotatate and again had a good response, and there was no toxicity over this long period. This is an unusual example, but showing in a patient with well-differentiated high-grade neuroendocrine tumor that they can truly have a very good benefit for a very long period of time with this sort of approach. And then this is the largest retrospective publication that I was able to find of approximately 150 patients, again, a variety of different tumor types, and the median progression-free survival in this case was about 14 months with, again, very limited toxicity. So all this data, although retrospective in nature, as I mentioned, is definitely supportive of the fact that PRRT does appear to have a good role in the treatment of patients with well-differentiated G3 tumors, less of a role for those patients with poorly differentiated G3 neuroendocrine carcinomas. So in summary, very important to keep that differentiation in mind in terms of well-differentiated versus poorly differentiated histology, and also highlighted the importance of these different Ki67 values, 3% to differentiate between well-differentiated and intermediate grade, low grade versus intermediate grade, 10% for when you would consider starting to get an FDG PET scan in addition to somatostatin receptor PET, 20% the difference between intermediate grade and high grade, and then 55% for the differentiation between well-differentiated and poorly differentiated high-grade tumors. So I discussed the universal role of conventional imaging for all of these patients, and of course the critical role of somatostatin receptor PET for selection of patients for PRRT, and the role of FDG for higher grade tumors and for possible prognostication in this group. And I would say that the preliminary data seems to support that the role of PRRT is primarily limited but convincing for patients with well-differentiated G3 neuroendocrine tumors, but this definitely needs to be evaluated in the larger ongoing prospective clinical trials that are happening right now. So we'll be excited to see those results when they come out. So with that, I will stop, and thank you very much for your attention.
Thank you, Dr. Mitra. I'm sure you are live now for a couple of questions. It was a wonderful talk, Though the data is limited, you try to cover most of the aspects of G3 neuroendocrine neoplasms. Uh, I have a couple of questions for you, especially with regards to G3 NENs. There have been a couple of studies where capecitabine temozolomide has been used for redifferentiation. In order to get the G3 tumors back to having gallium dotatate expression, that is somatostatin receptor expression, so that these tumors can be treated with PRRT. Do you have any experience or clinical data to support this, or any kind of trials which are ongoing for this?
Yes, thank you for that question. And once again, thank you for inviting me to give this presentation and be a part of this symposium. To answer your question, here in the United States, again, we're quite limited, I would say, with the capacity that we have to do some of these combination studies. I completely agree with you, as was mentioned, that this type of combination approach is one of the ones that are being looked at in some prospective trials that are ongoing. But yeah, we don't have any specific data on that as yet. I am hopeful, though, that we will have some good data from that soon.
And in particular scenarios where you have DOTA scan positive but FDG scan negative in G3 NENs, do you still add chemotherapy purely based on the histopathology of high grade neoplasm, or you just stick to PRRT?
Can you repeat that question again in
So
terms
when
of?
you have a high G3 NEN which is dotatate positive but it is negative on FDG PET, there are scenarios where you get FDG negative but a high grade neuroendocrine neoplasm. Uh, Purely based on the histopathology of a high grade neuroendocrine tumor, do you still add chemotherapy, or you just stick to PRRT just because the tumor is only expressing somatostatin receptors?
Yeah, again, a very good question, and one that's a little bit difficult to answer in terms of a uniform response. I think in terms of clinical applicability within the United States, especially, we would have to stick to only one type of modality versus the other. As Dr. Das also mentioned, combination therapies are very difficult to do for us clinically, although it can be done as part of research trials. So for the most part, we would just stick to PRRT in that indication. But I think those combination approaches are very important to look at in the future.
We have one question from the audience from a medical oncologist.
Somatostatic analog and wait for the progression to use PRRT.
In case of low volume G3 NENs, do we need to give PRRT just because it is expressing somatostatin receptors, or we can use somatostatin analogs for them? And then
I think that's
use PRRT as an option when there is disease progression.
correct. Yeah, I would wait to make sure that there's disease progression, even with patients with well-differentiated G3 tumors. Sometimes, surprisingly, the disease can be relatively stable for quite some time, and I think using somatostatin analogs, if they are still available and working for the patient, are a good first choice, and then saving PRRT for when progression happens.
Thank you, Dr. Mitra. Thanks for the wonderful talk, and you have answered all the queries and clarified doubts regarding the grade 3 neuroendocrine neoplasms. Thank you for taking out time at such odd hours, and pleasure to have you. I think there's one more question from the audience there. How would you
Yeah, I think I see the question from in the chat. Yeah, how would you go further if you find equal uptake on FDG scan and dotatate scan in G3-NEN? In that case, as Dr. Das mentioned, there's prognostic value in the information from the FDG scan, but in terms of choice of therapy, we primarily base it on the dotatate scan. So if there's sufficient uptake on dotatate across all the lesions, even if there's uptake on FDG, we would probably first go with PRRT. But again, I think this is a perfect example where combination therapies in the future are probably going to be the right way to go. Yes, that's Dr. Das just mentioned exactly what I said.
Great. So that pretty much sums up our discussion on the therapeutic aspects of neuroendocrine tumors.
If there's a high volume disease in a G3, would you prefer to use PRRT plus somatostatin analog, or you would prefer a K10 plus PRRT kind of approach?
Okay, so in case of again high volume disease in neuroendocrine setting, do you add somatostatin analogs to PRRT, or you just leave it at PRRT and or add any other chemotherapy? So basically, is there a role of somatostatin analogs in case of grade 3 neuroendocrine neoplasms in addition to PRRT?
Yeah, all of these are wonderful questions. There is again data from the NETTER-1 study in terms of how it was developed, as well as some retrospective data on lanreotide that using the combination of somatostatin analogs plus PRRT appears to have some benefit over PRRT alone, but there hasn't been very good separate randomized information on that, so it's a little bit hard to say. I do think that if the volume of disease is high, it's probably not a bad idea to use that approach, knowing, however, that the data isn't entirely there.
Thank you, Dr. Mitra. Thanks for having participated in this session, and your experience has helped us in learning new things. Thanks for joining once again.
Yeah, thank you so much for having me. Really appreciate it.
We'll be starting the next talk in a couple of minutes. A 2-minute break before Dr. Subhash starts his next talk. So we'll have a couple of minutes break, and then we'll be starting the next talk, which is on molecular markers in neuroendocrine neoplasms. The talk will be given by Dr. Subhash Yadav. Well, as we learned from the last two talks, what determines the treatment in neuroendocrine tumors is more of the exact histopathology, whether there is heterogeneity, whether there is no heterogeneity, how do we add therapies, and whether a combination really needed or not. So what defines and what decides is the histopathology. But it's not just histopathology, there are many molecular markers which are coming in, and to talk on that we have Dr. Subhash Yadav. Dr. Subhash is Associate Professor in the Department of Pathology at Tata Memorial Hospital. He is a very active member of the Neuroendocrine Tumor Multidisciplinary Clinic at Tata Hospital, and we would be taking a couple of minutes before he starts his talk. So let's wait for a couple of minutes before we begin the talk. I request all the audience, that is the delegates who are online and offline, to stay logged in and before we start the talk. After a short break, we'll be starting the session, and as I explained, we'll be now having a talk on molecular markers in neuroendocrine neoplasms. It is neuroendocrine neoplasms present and future from the pathology perspective. We have Dr. Subhash Yadav, who is a consultant and associate professor in Department of Pathology at Tata Hospital. Welcome, Dr. Subhash. Over to you.
Thank you, Amay, and the organizers. So my topic is neuroendocrine neoplasms, the present and the future. So to begin, so what are neuroendocrine neoplasms? These are a heterogeneous group of neoplastic epithelial proliferation, and they range from well-differentiated tumors to very aggressive polydifferentiated carcinomas, be it a small cell or a large cell neuroendocrine carcinoma. For establishing a diagnosis is by symptomatology, biomarkers, imaging, and finally by histopathology. So till today we are doing, however sometimes the diagnosis can become difficult as symptomatology is subroutine and it's non-specific, while imaging requires sophisticated technology and is expensive and not always widely available. So what does clinician want from pathologists while dealing with neuroendocrine neoplasms? They want us to be more precise and have an unbiased diagnosis. The various parameters used in the classification like mitotic count, the MIB or the Ki67 and necrosis to be stated clearly. And as we know that neuroendocrine have a site-specific nomenclature as per the WHO. So depending upon the site there is varied nomenclature for neuroendocrine neoplasms. There has been an attempt to make it a uniform nomenclature across the organ systems so that the clinicians accept it widely. However, and because of the varied nomenclature, there is a confusion among the pathologists as well as the clinicians, whether it's a neuroendocrine tumor grade 3 or neuroendocrine carcinomas. However, as we can see here that in lung we still follow the carcinoid, atypical carcinoid criteria. In pancreas we have a well-differentiated neuroendocrine tumor grade 3, a neuroendocrine carcinoma, whereas in other places we follow a grade 3 as a carcinoma. There had been an attempt to classify them, like we can see in this we have a 2015 classification which was on the basis of small cell, large cell carcinoid, but in the upcoming 2021 classification there has been an attempt to make it uniform as per the other organ systems. But still, till date, we are still following the carcinoid and the atypical carcinoid. Why is this in lung? Because majority of the lung neuroendocrines are polydifferentiated, being it a small cell or a large cell, and very small proportions are true carcinoids or atypical carcinoids. So this is how a pathologist uses the diagnostic criteria for diagnosing a typical and atypical carcinoid. So usually less than 2 mitosis per 2 millimeter square, there is absence of necrosis, and a size more than 5. In atypical, everything can be same. The mitosis increases, it has to be between 2 to 10, and or necrosis is present. This is a histomorphology pictures which show an organoid pattern. There are it can show glandular, but those are pseudoglandular and nests of tumor cells. Neuroendocrine tumors have a varied pattern. There can be rosette, there can be spindle cell, oncocytic, papillary. This may lead to a diagnostic dilemma. In large cell, it looks like any other epithelial carcinomas, but the mitotic index is high, like more than 10. There is necrosis, sometimes large cells, and in comparison to small cell where there is scanty cytoplasm, crushed nuclear morphology, hypochromatic cell, these cells usually have a low N/C ratio. They look like any other carcinomas. They have nucleoli. They may have fine or coarse chromatin, but on immunohistochemistry they show positivity for neuroendocrine markers, which may be one or more. Typically, we use synaptophysin, chromogranin, INSM1, and CD56. Similarly, when we come to gastropancreatic, again the classification is based on the basis of morphology, the mitotic count, and the Ki67. So as we see, grade 1 less than 2 mitos, MIB1 labeling index, and so on. And the carcinomas now are classified those which have more than 20 mitosis, more than 20 MIB, and a polydifferentiated morphology, be it a large cell or a small cell carcinoma. Thus it involves integration of both the morphology as well as the proliferative index for classification. So these were the changes in the current WHO, that there were some changes in the cutoff. Initially, less than for grade 2 it was less than 2. Now it has made less than 3 for MIB1. There has been removal of grade 3 neuroendocrine carcinoma, which was used in the past. Now there is a neuroendocrine carcinoma as a separate entity, and we have a neuroendocrine tumor which can be a grade 3. Again, this is how morphology can be solid, cystic, and the patterns as we described can be variable. So like you have nest, glands, a sheeted pattern. We have to carefully look for mitosis, because it drives the classification as per the number of mitosis per 2 millimeter square. And these are the new immunohistochemical markers like chromogranin, synaptophysin. So as the tumor becomes poorly differentiated or undifferentiated, we can make out that there is decrease in the expression of the neuroendocrine markers. So many times you may not, ideally they say for diagnosis you should have at least 2 neuroendocrine markers positive, but sometimes you may not get that, as there is loss of expression when the tumor becomes poorly or undifferentiated. So there is a need of new markers or a big battery of immunohistochemical stains to diagnose a poorly differentiated neuroendocrine tumors. Many times we receive biopsies which are very crushed and very small, and morphology may not be distinct. In such cases, MIB1 can be helpful to diagnose, to grade the tumor. Like you can see, there is hardly any MIB1 here, and this tumor has full of staining for MIB1. So more than say 90% here, with a crushed morphology becomes a small cell carcinoma. So there are some issues of Ki67, especially because of tissue fixation, the storage time, like if there's a big time gap between the specimen resected and sending to the pathology lab, there is drastic decrease in the MIB1. For all these reasons, MIB is still not used as an indicator in lung, because it is not a better predictor than mitosis, and there is no specific threshold for typical and an atypical carcinoid. So in lung, whether it has a role in tumor grading, it has any predictive role? No. There may be a prognostic role, probably if the tumor has a high MIB, you may say that it may not behave properly. So now this was all about how we practice now as per the neuroendocrine tumors, using the immunohistology, the immunohistochemical markers, giving importance to your mitosis, MIB. Now in the last decade there has been a lot of discoveries as per the molecular signatures. So I'll divide it into lung and gastropancreatic because they share a difference in the molecular signals. So when we see neuroendocrine tumors of the lung, like carcinoids, they usually have a low mutation rate, and they have been divided into 3 molecular subgroups. One is the cluster A, which is the true carcinoid, which usually shows overexpression of ACL1, DLL3. Then there is a cluster 2, which has another set of mutations, a ROBO1, SLIT1, as well as HNF1 and FOXA3. This was A1, A2, and there is a cluster B, which has some overlapping with the gastropancreatic neuroendocrine tumors, which they show somatic mutations in MEN1 and FOXA3. So this is how the clusters are divided. So these are the 3 clusters, and as we see that they have a difference in as per their molecular signatures, they have difference in their survival. The cluster 1 has a survival of 80, overall 10-year survival of 88%, cluster 2 has 83, and the cluster 3, which has MEN1 or HNF or FOXA3, has a survival of 60%. So similarly, the large cell neuroendocrines are also divided into in 2 groups. The carcinomas typically harbor a TP53 or a retinoblastoma 1. There is a high frequency of this and loss of RB1 identified. Across the neuroendocrine tumors, neuroendocrine carcinomas, be it at different sites, this P53, that is tumor suppressor gene 53, and RB1 inactivation is uniformly found. In addition, they are divided into 2 groups. One is like a small cell lung carcinoma like genomic profile. So morphology, it may look like a large cell carcinoma, but its genomic profile are like a small cell. Another is Same, it has some overlapping with mutations seen in adenocarcinomas, be it P10, KRAS. So these these two subsets are there for large cell neuroendocrine. So they have been divided into two groups. One is P53 is seen in both. In addition, this group will have ACL1, DL3 or notch low, and the other group will have the reverse of this. They may have a neuroendocrine profile which is similar to small cell, and they can be treated or targeted as per their mutations. So that this is the reason why it is necessary to subtype all the neuroendocrine tumors as per their molecular, because we may have targeted therapies in future. So coming to small cell again, as I said, that all carcinomas have inactivation of RB1, or there is a biallelic inactivation of PP53. This is uniform across the board. Small cell additionally has Notch family genes abnormality in at least 25%. Those which may have overlapping with adenocarcinoma like morphology, or may harbor say KRAS or any kinase gene mutations are also reported, but this is a very small proportion. More than 70% will have classify small cells in the last decade. So there are various authors which have been divided into initially divided into two groups, like the ASCL1, group 1, Neuro D1 is other group, and those which were negative were quoted as group 3. So last decade has been seen a lot of changes in this. There has been subclassification. So group which was double negative was found out to be harboring two other mutations like the YAP253. So although this is this recent paper which proposed a nomenclature that the small cell lung carcinomas can be molecularly divided into 4 groups. One is the small cell lung carcinoma A, which is the ACL1 high group. The second group can be the Neuro D1 high. The third group, which stands Y, is the YAPN, and the fourth group is the PU2F3. So this is how the current nomenclature has been proposed. This is not accepted or divided, but this is what Rudin et al. Had proposed. Why he did this? Because when we compare this to histology, the group 1 and the group 2 has a pure histology. They demonstrate the neuroendocrine markers, which is like synaptophysin, chromogranin, INSM1, CD56. Whereas the other two groups, they have low expression, they may not have uniform expression of immunomarkers of neuroendocrine. They have low expression of ASL1, Neuro D1, and they have increased expression of YAP or PU253. So this was they quoted, that when we classify them as per this neuroendocrine groups as per their molecular signatures, we can have a targeted therapy along with directed against them. So it is necessary, rather than treating them as one basket, they quoted that this has the mutations associated with ASCL1. So these are the potential targets available for them. So this is how they propose to treat and classify. This tells us the need that why we should molecularly classify the neuroendocrine tumors. So as I said, like this is a neuroendocrine carcinomas, maybe small cell, large cell. These were the 4 groups which we just described, and the large cell we had 2 groups, 1 and 2, and a small cell like large cell neuroendocrine carcinoma. Across the groups, the mitosis is high as per the histology. The MIB1 is high. The key genomic mutations are the P53 and the RB1, and the survival is less. So this is what we see at histology, but molecular level they are totally different from each other. So this is where we have to target the patients to have a better treatment of the patients. Coming to gastropancreatic, again pancreatic nomenclature keeps on changing again and again. So this was the nomenclature which we have, which has a grade 3 neuroendocrine tumor and a neuroendocrine carcinoma. This created a lot of confusion. Now the WHO says that tumors which have a small cell or a large cell morphology should be classified as neuroendocrine carcinoma, and there should not be any grade attached to it. So they become a neuroendocrine carcinomas Whereas grade 3 neuroendocrine tumors are those which are reminiscent of neuroendocrine tumors but have a mitosis of more than 20 or a MIB of more than 20. Most of them have a mitotic MIB1 less than 40%, whereas tumors which have a MIB1 of more than 55% go into neuroendocrine carcinomas. So the gastropancreatic neuroendocrine tumors, most of them harbor these mutations, be it MEN1, commonly seen in familial cases, the DAX, ATRX, the PTEN or the tuberous sclerosis protein. So the familial ones, majority will show MEN1 in addition to VHL, NF gene or tuberous sclerosis. When we come to sporadic types, the DAX, ATRX is which are mutually exclusive, is the most common mutation seen. Second is MEN1. So again, in GI or gastropancreatic, it is important to identify because they have prognostic significance. So mutually exclusive somatic inactivating mutations in either DAX or ATRX is reported in almost 40% of the cases. So what happens? So what they do, they result in telomere dysfunction. So telomere is basically how the cell life is calculated. So this results in the non-homogeneous homologous end joining, which results in alteration in telomere length and causing genomic instability. So the cell which are supposed to die or has to undergo apoptosis undergoes some genomic instability and undergoes proliferation. So as I said, like the morphology can be anything, but the molecular signature can be different. So this is ATRX which is retained, but the DAX is lost. This is another case which shows ATRX loss and DAX is retained. So these are mutually exclusive in most of the cases. Still, we can have some cases with the molecular signatures. There are IHCs which are available, so it can be done at a faster rate. Instead of going for a long time-consuming molecular, this can be done as per your routine testing. So when we see ATRX and DAX, ATRX is the one which has more significance in comparison to DAX for survival, because patients with a loss of ATRX have a 10-year survival of 54 and 0, 5 and 10 year survival of 54 and 0 is as compared to those which have retained ATRX. Additionally, multivariate analysis showed that the risk of LVI, perineural invasion, is more in ATRX loss, and the overall survival is poorer with ATRX as compared to DAX. So, as I said, we can do this in your routine lab while doing your HNE. Look at the morphology. If there is a high grade morphology with a high mitotic and a high MEB, you can do your testing for ATRX and DAX. If there is loss, it becomes a neuroendocrine tumor grade 3. Or if it shows loss of P53 or the RB1, because RB1 also can be tested by IHC, it becomes a neuroendocrine tumor. So till this level you can do in your using your immunohistochemistry. So this was a paper in 2018 which showed that loss of ATRX has a markedly decreased overall survival compared to those patients with retained ATRX. However, when DAX was negative, there was not much of difference in the overall survival. When we come to metastatic pancreatic neuroendocrine or gastropancreatic neuroendocrine, they in addition to DAX, ATRX, they may show ARID1, CDKN2A mutations. So patients which do not harbor these mutations have a better survival, whereas if harboring these mutations, either of these markedly decreases the survival to around 40%. So as we discussed, neuroendocrine carcinomas have this loss of retinoblastoma 1 gene or TP53 mutations. It's seen almost in 50 to 70% of the patients. And last two slides about the recent NET test. So NET test is basically like your using your liquid biology, liquid biopsy. So this is more useful in identifying patients who are asymptomatic or who do not have any specific symptoms but are at a risk, and you want to screen them, or whether you want to check the response to treatment or the progression of the disease. You can do a NET test, which is basically identifying the mRNAs, and using mathematical algorithms you derive a score which will give you the where the patient stands in this. So basically it's a transcriptomic signature for neuroendocrine tumors and has a good accuracy. So it will capture what is the tumor biology, what mutations it has, and the disease activity as per its genomic content. So less than 20 indicate there is no disease, whereas 21 to 40 in a patient who has a disease will indicate there is a stable disease. With increase in score, it indicates that there is a progressive disease. So this is how this has been used in Western population. It's not done here, but this is how they can stage, or this is how they can stratify or triage their patient that who is progressing, instead of going for tissue biopsies, which gives you your findings of that moment. Comparison in compared to that, liquid biopsy will give you a real-time overview of what is the genomic activity of the tumor, what mutations it carries, how much is the tumor burden right now, and how it has evolved over the time. So with multiple tests, it will tell you whether the patient is progressing, it's stable, or is responding, and it becomes a real-time information at a very faster rate. So this is about NET test. So this is my final slide for how to conclude. That the molecular signatures in neuroendocrine neoplasms is ever evolving. It gives an idea how the tumor going to behave, and also to categorize the tumor in different groups for better targeted therapy as well as for the patient care, and in future to identify more genomic signatures to classify and treat them as a separate patient rather than a one basket of patients. For pathologies, if you don't suspect a neuroendocrine tumor, you cannot detect it, because morphology is very much similar in cases of especially large cell neuroendocrine. It may look like any other carcinoma. So you should have a strong suspicion to identify a neuroendocrine tumor. Thank you.
Thank you, Dr. Subhash. A couple of questions from my side. Especially in case of pancreatic neuroendocrine tumors in grade 2, which is the preferred molecular marker in a resource constrained setting like ours, if we have to prognosticate a patient? ATRX should be the one single marker we should use.
Ideally, all neuroendocrine tumors will have ATRX or DAX, which is the most common. What we can do at our level is ATRX, because it is easily available. First of all, because if you say resource constraint, and it's a nuclear marker, so its reporting is also better. You can report it better. It is not non-specific staining is less in those, and it has a good correlation with the overall survival also.
And in case of non-pancreatic JEPNETs, is there any role for molecular markers, especially the rectal NETs, where the outcome is already poor?
So non-pancreatic, ideally the mutations are more or less similar, but right now there is no role for it. So we have to go for pancreatic. Yes, we have to classify. Most of the GI or gastropancreatic will show MEN1 mutations, but right now we don't target them that way.
Thank you very much. I don't think we have any further questions. Thank you, Dr. Subhash. Yeah, sir.
Listen, multiple perspective. So if we do say ATRX, if positive, you showed the outcome is good, mutations is there, and if not, outcome is really poor. And it's 20 versus 69. And it looks like what you're saying is true for any neuroendocrine tumor, yes, any part of the body.
So for tumor, not for carcinomas.
Not for tumor, correct. But what it means that if it is negative, looks like they're behaving like carcinoma. Am I right?
If it's negative, yes, they are behaving like carcinoma.
Okay. And
there may be some other mutation which we have not tested, or it's not in the discovered now, which is driving the disease and behaving aggressively.
But it's a good predictor. Yeah. So, so has there been any movement in trying to intensify treatment for these patients? Because 0% it looks like we are talking about a neuroendocrine tumor. If we tell our patients, we have a feeling we are talking about some slow growing. Here it looks like there is a type of it which is really not slow growing. It is not. Because I also, but I agree, we should have been answering that question, but I thought you have.
In our practice also we don't do also ETRX.
We don't do.
We don't do in our routine practice.
Achha,
as such.
okay.
We should be like off late we have started doing on pancreatic,
Uh-huh.
but this,
Others?
because this data is also all very recent, last
Uh-huh.
2 or 3 years. But as a protocol, we should be doing in all neuroendocrine. We have ATRX IHA in our lab. We should
Oh.
be doing in that.
Please.
We should do that.
This
We have
will be
started-
very valuable
No,
information.
me and Amay, like we have discussed also. Like we do it in pancreatic, but we should be doing in all neuroendocrine.
Okay, so very nice presentation. Thank you.
Thank you. Thank you.
Thank you, sir. Thank you, Dr. Subhash. Wonderful talk and nice practical inputs regarding the use of molecular markers. Well, we now move on to the next speaker. Our next speaker for today is Dr. Raghav Kashyap. Dr. Raghav Kashyap is MD in nuclear medicine. He had a stellar academic career in PGI Chandigarh, following which he was a consultant in the Department of Nuclear Medicine at Mahatma Gandhi Cancer Hospital in Vizag. And now he is working as a fellow in Theranostics in Peter MacCallum Cancer Center in Australia. Dr. Raghav has special interest in the field of theranostics in prostate cancer and has worked in great deal in that setting. So welcome, Dr. Raghav, and we are eager to hear from you.
Good afternoon, everyone. Today I'll be discussing about the topic of emerging theranostics for prostate cancer. So before I begin, I would like to express my sincere thanks to Dr. Ameya for giving me this opportunity to present in this scientific forum. With regards to the disclosures, I do not have any conflicts of interest to disclose. But at this juncture, I would like to acknowledge my thanks to Professor Michael Hoffman of Peter MacCallum Hospital for sharing with me the details of the several trials that have been conducted at the Peter MacCallum Cancer Hospital over the last few years. Theranostics is a familiar word to all of us, and it is formed by the combination of the words therapy and diagnostics. In the process of carcinogenesis, the cancer cells show certain genetic markers or cell surface or circulating markers called as the biomarkers, and we can make use of these markers for the diagnosis of the cancer. Many a times in many cancer cells and many types of cancers, we can even target these markers, especially the genetic markers, to try and control the growth of these cancer cells, and hence the combination of detection of a particular marker and using that for treatment of the cancer as well gives rise to the term theranostics or the concept of theranostics. In nuclear medicine, we have being witness to this wonderful concept of theranostics for several decades. And the first and a very beautiful example of theranostics has been radioiodine therapy, wherein we can diagnose carcinoma thyroid by using iodine 131 for scanning and as well as treatment of thyroid cancers. There have been other examples of theranostics in nuclear medicine, such as the radioimmunotherapy for lymphomas, the bone seeking agents, and then somatostatin receptor imaging and therapy for neuroendocrine tumors, and of late the PSMA diagnostics and therapy. Prostate specific membrane antigen or the PSMA molecule is a cell surface molecule which has enzymatic activity, and several traces have been developed to target the PSMA molecule. The first tracer which was developed was the 7E11 antibody. This unfortunately was targeting the intracellular component, and which was not very successful unless you had necrotic or dying cells wherein it can bind to the intracellular component. But recently there is there has been development of targets to the extracellular component such as the J591 whole antibodies, and the development of small peptide molecules based on urea such as the PSMA molecules. So I will be discussing about recent trials in theranostics in the prostate cancer and combination treatment strategies that can be used or that are being developed for prostate cancer in the field of nuclear medicine. We have a wide array of tracers which can be used for diagnosis of prostate cancer, such as the PSMA11, F18 based tracers such as the PSR and PSMA1007 and so on. And when I did a search on the clinical trials website for trials on PET in prostate cancer, I could see more than 180 active trials which are recruiting on the role of PET in prostate cancer that are currently being conducted. So the scientist is not a person who gives the right answers, but he is the one who asks the right questions. So we will try to address some of the important questions in theranostics in prostate cancer in the subsequent slides. The first question which we are going to address is how the PSMA PET compares with conventional imaging modality. So one of the landmark trials which deals with this is the PRO-PSMA study, which was published in the Lancet. So coming to the details of the PRO-PSMA trial, this was a multi-center randomized trial conducted in over 10 centers in Australia, and all the patients enrolled in this trial had a histologically confirmed diagnosis of prostate cancer and no staging imaging done prior to enrollment. The conventional imaging arm in this trial included bone scan and the CT scan, whereas the comparative arm was a PSMA PET scan, and the primary endpoint that was analyzed in this trial was the accuracy of the imaging modalities. The secondary endpoints included the impact factor of the imaging modality on the clinical decisions, and number of equivocal studies or the percentage of equivocal studies, and the radiation exposure from each of these studies in the arms. So if after being randomized into one particular arm, if the patients were noticed to have less than 3 metastases on staging procedures, the patients selectively underwent crossover to the opposite arm as well, and then the accuracy of the second line imaging and the impact of the second line imaging was also estimated in this particular trial. So when we look at the results, we can see that the accuracy of the PSMA PET was much better than the conventional imaging arm, and the impact of the imaging modalities was analyzed by giving a questionnaire to the referring clinician, and before and after the investigation was done to see how the management was impacted. So the impact of the management was also much higher with the PSMA PET scan, and the number of equivocal studies were much lower in the patients who had a PSMA PET scan. The radiation burden was also much lower in the patients who had a PSMA PET scan. We can see the details here. Again, the area under curve for the PSMA PET is much higher, seen in the red. We can see that the radiation burden in the bottom, we can see that the patients who underwent a PSMA PET scan received up to a total of 9 millisieverts, whereas with the combined bone scan and the CT scan, contrast CT scan, the radiation burden was up to 19 millisieverts in these patients. So this trial definitely documented the superiority of the PSMA PET scan for staging compared to the conventional imaging. Now if we come to the detection of the prostate cancer, we have multiparametric MRI, which is a very beautiful test, and we can characterize the lesions beautifully on the several stages or the components of the multiparametric imaging. However, if the multiparametric imaging shows certain grades of pyrites, especially the pyrites 2 or pyrites 3 lesions, the chances that they are false positive is quite high, as evidenced by this particular trial which was published in the Lancet. And among 418 patients who were deemed to be of having a clinically significant prostate cancer on MRI, almost half of them were negative on biopsy. So this is one of the shortcomings of multiparametric MR imaging. So the next question we try to ask is, if now we know that PSMA PET is very good in staging, is there any additional value of doing a PSMA PET along with an MRI for diagnosing prostate cancer? This particular was addressed in the primary trial, which is published recently in the European Urology Journal. So the patients recruited in this trial had a suspicion of prostate cancer with elevated PSA and a positive digital rectal examination. Almost 296 men with suspected prostate cancer were included in the trial. They underwent multiparametric MRI and a biopsy and a PSMA PET scan. The primary endpoint in this trial was to see if the negative predictive value of MRI could be improved by combination of the PSMA, by adding the PSMA findings to the MRI. And the secondary endpoints that were analyzed was to see if we can safely avoid biopsy in certain group of patients if we combine the interpretation of both MRI and PSMA PET scan. So when we go to the results, in this particular trial, the patients included in this trial, the negative predictive value for MRI for clinically significant prostate cancer was 72%, and with the addition of both PSMA and MRI findings, the negative predictive value improved significantly to 91%, which meant that you would miss much lesser percentage of clinically significant prostate cancer patients when you combine both PSMA PET and multiparametric MRI imaging. This small percent is due to of course certain number of few small percentage of patients who do not express PSMA receptors in spite of harboring the malignancy. Coming to the secondary objectives, when you have an equivocal report on the MRI, as in with the PIRADS 2 or 3 scores, and if you had a PSMA PET which did not show any abnormal uptake, you could probably observe or safely avoid the biopsy, unnecessary biopsy in these patients, in up to 38% of these patients. Now another endpoint which was explored in this trial was to see the positive predictive value of PSMA PET, and an absolute cutoff for the SUV value was derived. With a positive MRI of PIRADS scores of 4 or 5, the PSMA PET value showing an SUV of more than 9 had 100% positive predictive value, and irrespective of the MRI findings, SUV of more than 12 had 100% positive predictive value in this particular study. So this calls for including PSMA PET in the diagnostic algorithm, especially when you have unequivocal findings of PIRADS 1 to 3 on an MRI, and you could probably do a PSMA PET scan to decide whether or not you need to go ahead for the biopsy. Now we can again at this point raise a question as to if we can use PSMA PET actually to direct the site of the biopsy and to increase the yield of biopsies in these patients. This is being explored by two very interesting trials. One of the trials is being performed at PGI in India from Chandigarh. They tried to use robotic arm and use the PSMA PET to guide the site of the biopsy using a robotic arm, and the approach was transgluteal approach. The trial appears to have completed recruitment, and we would be eagerly awaiting the results to see how they turn out. Another trial, the primary 2 trial, is also being conducted on a similar line to see the additional value of doing a PSMA PET in in these patients and to guide biopsy. So the next question which we will be addressing is, what is the impact of the PSMA PET on the management, and can you base your management decisions on the PSMA PET findings? The question here, if you put it alternately, is if you incorporated PSMA PET findings in your management decisions, would that result in better outcomes for the patient? So there are two very interesting trials which are looking at this particular aspect. One is the Oriole trial. This trial actually tried to evaluate whether or not doing a stereotactic radiotherapy in oligometastatic disease improved the outcome. That was the principal endpoint in this particular trial. And of course, the results of the trial show that there is definite benefit in doing stereotactic radiation to oligometastatic sites of the disease. As a secondary observation, all the patients in this particular trial underwent an F18-PSR PET scan. Now, the investigators analyzed if all the sites that were detected on a PSMA PET were included in the treatment, or if some of the lesions were missed because the treatment plans were actually based on conventional imaging and not on the PET. So when an analysis was performed categorizing the patients who received radiation into those who had all the lesions treated and those in whom not all the lesions were treated, again there was a significant difference in the outcomes for these patients. So if when the patients had all the lesions that were treated, showed significant better progression-free survival and distant metastasis-free survival on follow-up, compared to those in whom a few of the lesions were not included in the treatment plans. So these are the difference in numbers. So this study shows that treatment with stereotactic radiation for oligometastatic prostate cancer improves outcomes, yes, and the outcomes were significantly enhanced by total consolidation of the disease identified by the PSMA targeted PET scans. Another similar trial included the flucyclovin PET, which is an amino acid agent which can detect prostate cancer, and it has relatively high sensitivity for identification of prostate cancer. This trial is called the EMPIRE trial, and this was conducted in patients who had prior prostatectomy with detectable PSA levels. So now these patients were divided into conventional imaging arm versus the flucyclovin PET guided radiotherapy. So the radiotherapy volumes were defined either on conventional imaging, that is CT, or flucyclovin PET. Now, when analysis was performed for survival, the median survival was not achieved in both these arms. However, at 3 years, the event-free survival was much better in the patients who underwent flucyclovin PET, and the 4-year failure was also failure-free survival was also much better in the patients who underwent treatment based upon the flucyclovin PET defined volumes. So the conclusion of this study was that flucyclovin PET addition to post-prostatectomy radiotherapy decision making and planning significantly improves survival free from biochemical recurrence or persistence. So these two trials show evidence that if you planned your treatment based upon the PSMA PET, the outcomes could be much. Now we approach the next question. We have seen the diagnostic part of the PSMA, and now we move to the therapy to complete the theranostics concept that we are discussing actually. So is PSMA based theranostics a safe and efficient procedure? So we have lutetium PSMA which can be used for targeting the prostate cancer, and we look at the question as to if this particular therapy, how efficient it is and how does it stand compared to the other modalities of treatment that are in use. So A phase 2 trial was first initially conducted in 30 patients who had prior hormonal treatment with abiraterone or enzalutamide and at least one line of chemotherapy in the form of docetaxel. And among these 30 patients, more than 50% or around 57% of the patients showed more than 50% drop in the PSA. Very minimal side effect in the form of dry mouth was seen, although in a large proportion of the patients it was just grade 1 in severity, and grade 3 and grade 4 thrombocytopenia was noticed in just 13% of these patients. So encouraged by the results in this phase 2, a prospective, again a randomized control trial was planned, the therapy trial, which compared lutetium PSMA therapy to second line chemotherapy agent, the cabazitaxel. This trial was published in the Lancet in February this year. The primary outcome in the form of PSA reduction more than 50%, as you can see from the results, is much better in the lutetium PSMA arm, and the treatment with lutetium PSMA also had better progression-free survival at 12 months of almost 20% compared to 3% in cabazitaxel arm. The objective response rates were also much better with lutetium PSMA arm. The side effects less severe and fewer in the lutetium PSMA arm. Another important trial which is recently published in the New England Journal is the Vision trial. Here the investigators compared the lutetium PSMA with standard of care. The standard of care was defined as either bisphosphonate therapy, radiation, or hormonal treatments in the form of abiraterone or enzalutamide, and the standard of care did not include any chemotherapy, immunotherapy, radium, or other investigational drugs. So a 2:1 randomization was done in both lutetium and standard of care arms. The results of this study also show much better progression-free survival, radiologic progression-free survival with lutetium PSMA as compared to the alone, and again significant better overall survival and higher response rates in lutetium PSMA arm with complete response in almost 9.2%, partial response in 42% of the patients who were treated with lutetium PSMA. So now both these trials document that theranostics or therapy based upon PSMA targeting improves the patient outcomes in men with castrate-resistant prostate cancer following docetaxel and androgen receptor directed therapy. It is definitely much active than cabazitaxel in PSMA avid disease, and it shows fewer grade 3 and 4 adverse effects and improves the quality of life. At this juncture, I would definitely take this opportunity to mention very recently published phase 2 randomized trial from PGI in India again, and this particular trial compared lutetium PSMA with docetaxel in chemotherapy naive metastatic castrate-resistant prostate cancer. And I should take this opportunity to congratulate the investigators for having successfully completed this trial and getting it published. So the results of this trial show that the difference in the PSA response rates between the two arms met the criteria for non-inferiority as defined in the protocol. The PFS and the overall response rate were comparable in both the arms. The quality of life and the adverse effect profile was favoring lutetium PSMA therapy, and they concluded that lutetium PSMA was demonstrated to be safe and non-inferior to docetaxel in the treatment of metastatic castrate-resistant prostate cancer. So it's a very useful trial, and it calls for further consolidation of this information in form of much larger randomized studies. Now we have seen the utility in staging for diagnosis and the impact on the management, and we have also seen the evidence with regards to the efficiency of theranostics based upon the PSMA. Now there are a few more interesting areas which we can look into, such as, is there anything that can be that we can do to improve the outcomes with PSMA theranostics? This is a very beautiful slide which summarizes the areas of active research or that can be conducted with respect to PSMA theranostics. Now we can probably look into areas such as optimal selection of patients by using either radiomics or neural networking and artificial intelligence, try to see if there are any imaging characters that can predict the outcomes, and we can also base our selection of the patients upon FDG avidity of the lesions, and research is ongoing to see which factors favor better outcomes or influence the outcomes on both PSMA PET and FDG PET. Studies are also being carried on to see if the dose that is delivered to the tumor sites by dosimetric studies can influence the outcome of the PSMA therapy. Now lutetium PSMA does radiation induced damage to the tumor cells, and following the radiation induced damage and necrosis of the cells, there is release of antigens within the tumor cells into the circulation. Now one of the important areas which is being looked into is if we can add immunotherapy such as pembrolizumab at this juncture. Can immunotherapy potentiate or improve the outcomes with lutetium PSMA treatment? Now this is being evaluated in a trial called as the PRINCE trial, and another trial which I will be showing in the subsequent slides. Hormonal treatments like enzalutamide, they actually upregulate the PSMA receptors on prostate cancer, and there is a trial which is looking into the use of combination of enzalutamide with lutetium PSMA and trying to see the additional value of hormonal treatments with lutetium PSMA. For radiation induced damage, radiosensitizers or drugs such as the PARP inhibitors, which actually inhibit DNA repair, can be used, and this particular question as to whether there is any role of adding PARP inhibitors and whether it improves, has any influence on the outcomes, is also being looked at in the LUPARP trial. Now there are also other radioisotopes such as the alpha emitters and the Auger electron emitters which can be used for treatment, and whether they have any different outcomes compared to the lutetium PSMA, which is a pure beta emitter, or not. Again, several studies are being undertaken to look into this particular aspect. Sometimes, as for example in this patient, we can see that there is extensive bone metastasis and few sites of the disease are macroscopic, showing focal intense avidity, but there is also a diffuse marrow infiltration that can be seen on the PSMA PET. Following 3 cycles of lutetium PSMA therapy, the macroscopic sites of disease have responded, but the diffuse marrow disease actually continued to progress, and this was also reflected in the PSA levels in this particular patient, and actually the patient did not benefit much from the PSMA therapy. So one might wonder if using a low path length isotopes such as the alpha emitters or Auger electron emitters can target these sites of diffuse marrow involvement much better as compared to lutetium PSMA alone, and if at all, if you are planning to use these agents, should we use it as a combination with lutetium PSMA or as a sequential therapy? All these are unanswered questions, and we know from bone seeking radionuclides that although they are not directly targeting the tumor cells, they can improve the survival of the patients, for example from the data from the radium treatment. So is there a role of targeting the tumor microenvironment and whether that improves or changes the outcomes in any significant way? That is also a very interesting question that can be looked into. And of course there are many new targets which are being evaluated for prostate cancer, such as the gastrin receptors, the FAPI, and somatostatin receptors, especially when you have neuroendocrine differentiation of the prostate cancers. All these are very pertinent and very interesting questions which need further studies to be answered. This table shows multiple trials that are being conducted in Australia with regards to prostate cancer, such as we have discussed the therapy trial, and the PRINCE trial, as I have mentioned before, looks at the role of pembrolizumab with lutetium PSMA. LUPARP trial is looking at the role of DNA damage inhibitors, DNA repair inhibitors such as the olaparib as a combination with lutetium PSMA. And we have the ENZA-P trial looking at the value of adding enzalutamide, which upregulates the PSMA receptors to PSMA therapy. Now, combination of radiation with lutetium PSMA in oligometastatic diseases is being looked at in a POPSTAR 2 trial. Then we have the upfront PSMA trial, which looks at combination of lutetium PSMA with docetaxel versus docetaxel alone in chemotherapy naive high burden metastatic prostate cancers. And finally, but not the least, we also have the lutectomy trial, which is looking at delivering high radiation doses to the primary in the prostate gland prior to radical prostatectomy using lutetium PSMA. So we are moving from the last line of therapy to the first line of therapy with our therapy. These are various isotopes which can also be explored to see if they have any additional benefit to lutetium PSMA in treatment of cancer. Example of few of these trials looking at different isotopes and different targeting pharmaceuticals include in the clinical trials website are like the on the actinium PSMA, and then you have iodine 131 labeled antibodies and lutetium labeled to whole antibody, which I have discussed before, and then copper molecule as a diagnostic and therapeutic agent, the theranostic combination of copper PSMA for prostate cancer, and also there is another trial looking at lutetium PSMA prior to radical prostatectomy. So the future is not something that we enter, but it is something that we create. So it's a very beautiful saying. And with respect to theranostics in prostate cancer, actually I think we are creating a future for a definite role of theranostics and nuclear medicine in the prostate cancer with the right strategies and right studies that are being planned worldwide, and I think we are heading in the right direction. And at this juncture I would like to give a huge shout out to all the researchers worldwide who have made the above studies possible, and to all their teams and the team members, and most importantly to all the patients who participated in these trials to give us this information. Thank you.
Thanks, Doctor. Thanks, Dr. Raghav. Wonderful talk, and you have elaborated the various aspects of research in lutetium PSMA therapy along with the combinations. We have no questions as your talk was very lucid, and there was nothing that you left behind. You have covered everything right from beta alpha therapy as well as Auger electron therapy and the available targets that we have for prostate cancer both in the upfront and CRPC setting. So thank you, Dr. Raghav, once again. Since we have no questions, we'll move on to the next talk. Well, our next speaker is Dr. Vikas Prasad. Dr. Vikas is Deputy Director of Department of Nuclear Medicine in University Hospital Ulm in Germany. He has a special interest in theranostics, one of the early practitioners of theranostics from the Bad Burka group, and then he moved on to the hospital in Munich, Charité Hospital, and now he is the Deputy Director at Ulm. Many publications in national and international peer-reviewed journals, an honorable person in the field of theranostics. I welcome Dr. Vikas to give his next talk. He will be giving the talk live. So over to you, Dr. Vikas.
Thanks, Amya. It's always a pleasure to come back to the origin, and I really enjoyed all the talk. And I am thankful to the organizers for giving me an opportunity to speak on the tumor heterogeneity and theranostics of prostate cancer. So let us see what exactly is precision oncology. Why I have brought this definition is because many a times we use it interchangeably with theranostics and precision oncology. They are in many sense very much near to each other, but there is some basic differences also. So, but in general, I would say the precision oncology is a field which has got its thrust from the development in the theranostics by, for example, defining the targetable drugs on the tumor and use the targets on those tumor and use those targets for the treatment. Let us say the example of this immune therapy. I mean, we all know that immune therapy has actually revolutionized the treatment of cancer cells. But if you look at the response rate and you look at those patients who actually respond, it's not that all patients respond to that immune therapy. That 20 to 40% respond, and the rest may not respond to that. We really need to understand which of them actually responds and which do not. And it probably lies in the complexity of the carcinogenesis because we all know that the cancer cells, by the time they manifest themselves in a macroscopic form or in CT or MRI, by that time there are a number of mutations which have actually taken places, and so carcinogenesis is a multi-year process. For example, we are speaking about the prostate cancer now. We have spoken also about the neuroendocrine tumor, but let's just concentrate on the prostate cancer, and you will see that there is already 20 to 30 years gone before the prostate cancers actually make themselves manifest in the processes, diagnostic tools which we have. That means during this 20 to 30 years, they have developed a lot of mutational burdens, and they have developed the machineries to survive many different kinds of treatments which we offer to them, which we want to treat them with. What we also need to understand is when we use the treatments, cancer treatment, these cancer treatments are not always effective against all the different clones of cancer cells present within the tumor lesion. And that leads to a kind of a clonal selection. And because of this clonal selection, ultimately these tumor cells, the clones which are resistant to that particular kind of treatment, they become even more aggressive. It is very pertinent in the field of prostate cancer. I will show you why. But we have to remember this during the journey of the treatment of prostate cancer. First, this patient is a hormone sensitive, and then it moves into the hormone resistant or castrate resistant phase. And these different time period and the treatments which we offer during the 10-15 years of the journey of a patient through his prostate cancer, these treatment itself are producing some kind of a clonal selection, and they are pushing aggressiveness of these tumor cells. And we need to understand how we can assess and measure and take appropriate steps to prevent the aggressiveness of these tumor clones during a treatment. I have seen that this particular symposium is on theranostic within the lung cancer. So I thought that I'll show you an example of where we actually sometimes make a mistake by only concentrating on the classical TNM stage for the decision making of the treatment options available in lung cancer, for example, right? So this is lung cancer. I'll just show you this some example. We actually did an analysis of 81 patients, all the stage 1 and stage 2 patients with no adjuvant chemotherapy. Curative tumor resection was performed in all cases. We had in all patients the pre-therapy FDG PET CTs, and we followed the patient for 4.6 years. And we did the texture analysis. We quantified the lesions, texture, CT as well as PET texture. And then we tried to find out if there are additional parameters which can predict within this stage 1 and stage 2 operated patients, lung cancer patients, if there are additional prognostic parameters. So what we did observe was that within this stage 1 and stage 2, if we look at additional PET as well as CT and PET and CT combined parameters, for example, the PET solidity as well as PET SUV max and the CT volume, then these patients had a different overall survival depending upon which particular cutoff value you take over here. For example, CT volume greater than 1.4, these patients have a poor overall survival. For SCV max greater than 12.2, they have a poor survival. For solidity greater than 0.981, you have a poor survival. So that means within stage 1, stage 2, if you look at these image parameters, you can actually predict or look at the prognostic markers. And if you can inculcate these prognostic and predictive markers in your algorithm, there's a chance that you can improve the overall survival of these patients. So of course, size, number, and location may alone be misleading, and you have to consider the time factor. We also had a session on the neuroendocrine tumor. I think we all know that the PRRT is one of the most effective treatment options for the G1, G2, and probably in some of the G3 neuroendocrine tumors too. But sometimes the question comes up, as I mentioned, about the tumor selection during treatment. So previously, there were a lot of questions raised in the 2006-2012 period of my career that is PRRT leading to a clonal selection. For example, in this patient who was already treated with, it was a gastric net patient who was already treated with Y90 dotatate between January and March 2011 and showed an excellent response. Later on, the lesion started growing in the liver, and the question was raised whether this PRRT has led to the de-differentiation of the neuroendocrine tumor. So we have performed the MRI. MRI did not, at least this, you do have some parameters in MRI too, but in this liver-specific MRI, it was not possible to say which of the lesions are actually aggressive. So what we did the combined molecular profiling using the SSTR expression and the FDG metabolismus, and we found positive lesion, remained stable, and rest of the lesions actually responded very well when we treated this patient further with lutetium dotatate. So it's a kind of a patient selection based upon molecular profiling, which we can do in the PET, and this helps in the proper treatment. And if you have certain patients where some of the lesions are somatostatin receptor negative, some of them are showing intense somatostatin receptor expression, and some on the PET are showing only marginally increased, peripherally increased somatostatin receptor expression, then these patients may actually may not benefit from lutetium PRRT alone, because you can induce a kind of a partial a kind of a clonal selection. This is the classical example of a tumor heterogeneity with respect to the targets present. So this shows that the targets which we are using for the treatment, they itself can vary in the intensity of the expression. So what we learned from the neuroendocrine tumor, before I move to the prostate cancer, is that what we learned from the neuroendocrine tumor is that the somatostatin receptor heterogeneity, the degree of expression of the somatostatin receptors on the lesions, can itself be a predictive as well as a prognostic marker. So let us see which particular scenarios can exist and manifest itself in the PSMA theranostics and the PSMA heterogeneity. We have spoken very proudly about all the different theranostic approaches which we nuclear medicine physicians have been the pioneer of, I would say, starting from the radioiodine therapy. But we still have to learn a lot when it comes to the interaction of the radiation, internal radionuclide therapy with the tumor microenvironment. We have been relying in majority of the cases, the experience from the external beam radiation therapy. Well and good, you can do that. And if you look only on the example from the external beam radiation therapy, you will probably learn that there is a very complex interaction between the radiation, the tumor cells, and its microenvironment. Some of the radiation doses, leads to the upregulation of a certain non-prognostic or bad prognostic markers on the tumor cells, and some radiation dose actually leads to the killing of those and inducing sufficient double-strand DNA break. So the radiation is not equal and does not lead to only one single kind of response. It can be both ways. And this was actually done and looked at in a very beautiful study in the European Urology on the PSMA heterogeneity and their DNA repair defects in the prostate cancer based upon the H score. They found that those patients who have a higher heterogeneity of the PSMA expression, they have a poorer overall survival so this was actually looked at the cellular level. So there is a PSMA heterogeneity. This concept has to be understood and taken into consideration for driving the theranostics of PSMA radioligands in prostate cancer. There's a huge heterogeneity available. And then this is another preclinical study which also looked at which investigated the PSMA radioligand therapy efficacy as a function of the cellular PSMA levels and intratumoral PSMA heterogeneity. So the study design is presented over here. This is a beautiful study which you all should read that. And what they did was they calculated, they looked at different kinds of tumors with different expressions of the PSMA expressions, different intensity of the PSMA expression of the tumor cells, and then they treated with lutetium PSMA 617, and then they resected the tumor and also calculated the tumor growth. After the resection, they looked at the lutetium uptake and DNA damage induced and measured by the 53BP1. And on the right, let's look at only the tumor volume growth. So if the PSMA expression is very intense, the tumor volume growth is less. If the PSMA expression is mild, as is seen in the green line, probably the PSMA expression is actually a prognostic marker for the tumor growth, tumor volume 2 in this preclinical study. And look at this 53BP1, which is marker of the double strand break in the DNA. The higher the intensity of PSMA expression on the tumor cells, the higher is the DNA double strand break. So you see the heterogeneity of the PSMA has a significant role. Another important aspect which we all should understand when we are treating our patients and trying to interpret the PSMA expression on the tumor cells, that this PSMA might appear to be prostate specific, but it is not prostate specific. And some of the expressions of the PSMA, specifically, for example, in the primary tumor, can itself be influenced by the amount of folate present in and around in the microenvironment. So you see, PSMA is a metabolic enzyme, and the substrate can itself influence the expression of this PSMA. So this has to be kept in mind. Many of you might have read about it, but there is no clear-cut indication. For example, in the salivary glands, the uptake which you see, a very high intense uptake which you see, many say it's a PSMA expression. But if you look at the immunohistochemistry of the salivary glands, the immunohistochemical staining will reveal that it's not very intense expression on the cell. So still we are seeing such high PSMA uptake. So where is it coming from? The heterogeneity of the PSMA expression is also significantly influenced by the region of the location of the metastasis. For example, we know that in a liver metastasis of the metastasized castrate-resistant prostate cancer patients, the PSMA expression can be extremely heterogeneous. Some of them may be intensely PSMA positive, some of them only marginally PSMA positive. And I always tell my residents and I have learned it over the years, that one must look at the diagnostic CT also and look at the hyperdense lesions, because sometimes it does help you in interpreting the aggressiveness of that prostate cancer metastasis in the liver. So restricting ourselves to the PSMA expression heterogeneity. This slide again shows that the PSMA expression heterogeneity varies depending upon the location of the metastasis. But the question is, how can we measure and how can we improve it? Just knowing something does not help our patients. We must be able to quantify it. We must be able to move from the objective assessment, from the subjective assessment to the objective assessment. And there are certain ways of doing a textual analysis quantification based upon the PSMA PET CTs and develop parameters like entropy, which is a marker for the heterogeneity. And then you can look at the response of those patients. And if these kinds of markers, heterogeneity texture analysis markers, are validated in a large set of patients, probably we will be able to treat our prostate cancer patients very well. Let us not forget that only 1/3 of the patients respond to the lutetium PSMA therapy with a very good response. 1/3 show a stable disease, and 1/3 of the patients, despite showing an extremely intense PSMA expression, do not go on to show any kind of response. So there's something going on behind in which we have not actually understood it. And one of the factors which we must remember in mind is the neuroendocrine differentiation of the prostate cancer, specifically in the stage of the disease where the patients come to us. Under the treatment, those hormonal therapies can lead to the neuroendocrine cellular differentiation. And under the neuroendocrine cellular differentiation, we know that the PSMA expression can be extremely faint, right? So this is something which we really need to look at it, e.g. again by combining the using the molecular profiling, using the two beautiful validated tracers, FDG and PSMA. For example, in this case, this was a poorly differentiated neuroendocrine carcinoma. the biopsy came from a small mass lesion in the pelvic region, which was hypervascularized on the peripheral region and centrally hypodense necrotic lesion. And the biopsy showed that it is a aggressive tumor, as is shown with the Ki-67 80 to 90%. So the patient was referred to us, and we did the PSMA PET also. And what we observed that this aggressive mass lesion was only showing a peripheral increase in the PSMA, mild, extremely mild. Some of the lesions, lymph node lesions, as is seen in the para-aortic prevertebral lymph node lesions, some of them were showing PSMA expression, which was intense, and only faintly FDG uptake. So there was a tumor heterogeneity even in this neuroendocrine carcinoma aggressive patient. Not all neuroendocrine differentiated prostate cancer patients have no or faint PSMA expression. There are certain neuroendocrine tumor differentiated prostate cancer metastasis in liver, which can still have a very high somatostatin receptor expression. So just because a patient has a neuroendocrine differentiation of the prostate cancer does not mean that you say, okay, hands up, I cannot treat that patient. You must do the PSMA PET. For example, in this case, a classical case with heavily pre-treated with 9 docetaxel cycles, 28 cabazitaxel. I mean, these are heavily pre-treatment cycles. And even then, the patient have a very good PSMA uptake on the metastatic lesions, and we treated him 4 times, and the patient responded beautifully. Thanks, Amya, for your effort. We could actually bring this paper also on the target heterogeneity. Some of the patients with in this stage of the disease, metastatic castrate-resistant disease, as I mentioned, do show the neuroendocrine differentiation. So, which can be very well assessed also by, for example, combining the somatostatin receptor PET-CT and PSMA PET-CT, and you can then offer these patients additional treatment. For example, combining lutetium dotatate or only with lutetium dotatate and lutetium PSMA. The approach of the use of the dual PET-CT for characterization of the heterogeneity of the PSMA expression by combining PSMA PET and FDG has also been done in Australia several number of times, and we now have data to show that it also has an influence on the overall survival, right? So it does help. Where are we moving in the future? In the future, we will have to understand the basic structure of a cancerous lesions. We will have to develop a new peptides which higher affinity and higher circulation time to overcome some of the resistance of the prostate cancer despite showing PSMA expression. For example, in this case, we used this lutetium PSMA 201, only 500 megabecquerel, and the patient actually responded, although this was a dosimetry dose, but the patient still showed a beautiful PSMA response. The other way to overcome is, of course, by understanding the DNA damage repair and the genes which are responsible for the radioresistance and radioprotection. And of course, by switching over from the lutetium-177 to alpha therapy, because alpha induces higher DNA damage, double-strand DNA damage as compared to lutetium. So in those patients who are not responding to lutetium, still in those patients, the alpha PSMA works very well. So if we understand our mechanism of DNA resistance, of the radio resistance, then we'll be able to treat our patients much better. For example, we did hear about the olaparib combination. We have been doing at university on some of the patients we have treated in combination with lutetium PSMA. Those patients who are showing DNA damage repair genes, you can combine them together, lutetium PSMA and olaparib, and achieve a good and durable response. We are also doing how to move forward. That is a topic future. So we are also actually doing a liver biopsy or biopsy from the lesions to see if those patients are actually showing some kind of genetic mutations and find out the targetable drugs. and this should be done in patients who are having PSMA heterogeneity. We can also look at the germline gene variants and see if there is any kind of correlation with the response. For example, we did it. This was a study from the Bad Berka group from Richard Baum, and in this patient subgroup, heavy selected patient subgroup, we can identify check to germline mutations as one of the probable good prognostic markers, under which the patients can respond to beautifully to the lutetium PSMA. So this is the future. In some of the cases where the tumor heterogeneity is very, this PSMA heterogeneity is very intense, you can actually think about offering those patients, for example, CAR T cell therapy with PSMA targets, and we have treated a couple of patients, with one patient showing good response. The future is, again, as I've mentioned many a times, a combination of different approaches, different methods to characterize our patients well, and use this territorial management aspects for the treatment guide, which I think will be the future. The future cancer treatment will be performed directed by the cancer's lesions profiling and not based upon only on the primary tumor. So to conclude, heterogeneity of target expression has a deciding role in the efficacy of all radioligand therapies, specifically in prostate cancer. Watchful approach towards PSMA RLT is warranted. High response alone is not a guarantee for improving OS because of the heterogeneity of PSMA, and that is why we need to think about sequencing and combination, and also we need to understand much more about PET CT and PET-RMI images to understand the PSMA heterogeneity and guide our patients' treatment much better. With that, I would like to conclude, and thank you for the opportunity to speak.
Thank you, Dr. Vikas. Wonderful talk as always, and you have highlighted different aspects of heterogeneity in a very elaborate way. We have no particular questions, but one question from my side regarding the role of using FDG PET in planning therapy for prostate cancer. So, do you use a particular Gleason's cutoff beyond which you decide that now we are going to do FDG PET before going ahead with PSMA RLT, or there are any other biomarkers which you use in order to deciding whether FDG PET should be done for a particular patient?
Mm-hmm. Thanks, Simon. This is a very important point. So there is no particular cutoff per se which I can recommend as of yet. The study is going on. I have been doing FDG PET only rarely in my clinical practice. I'm relying more upon a PSMA PET CT, good diagnostic CT, and looking at the clinical parameters to come to a decision. But if centers want to do that, they should be looking at the cutoff value for the FDG because it has not been validated as of yet.
Thank you very much. Thank you, Dr. Vikas. We move on to the next talk now. Our next speaker for today is Professor Venkatesh Rangarajan. He is going to talk on theranostics of FAPI, that is fibroblast activation protein inhibitors in GI malignancies. Professor Rangarajan is head Department of Nuclear Medicine and Molecular Imaging at Tata Memorial Hospital, Mumbai. He is a very active proponent of newer tracers and theranostics and very passionate about using these new tracers once they enter into clinical practice. So let's hear from him about what is his early experience with FAPI inhibitors. Thank you very much. Over to Dr. Rangarajan.
Hello, good afternoon. So speaking about an interesting topic, a new product, a new peptide, gallium FAPI PET-CT in GI tumors. As a part of this talk, I think this is the last talk in the theranostic series. But it's very apt to put it in the last because I think this is going to be the major trendsetter and it's going to change the direction of the way we treat or we image many of the solid tumors. So the FAPI, the fibroblast activation protein, it's highly expressed in the stroma of several tumor entities. Breast, colon, pancreatic carcinoma show strong desmoplastic reaction. 90% of the gross tumor mass can consist of stromal and not tumor cells. Cancer-associated fibroblasts differ from normal fibroblasts by providing FAP as a target with relatively higher tumor-specific expression. FAPI has already been used as some of the cancer treatment. This diagram to show an example of, say, a gallium DOTA FAPI. What could be the mechanism of its action? The cancer tissue and its several of its environmental, the local tumor environmental participants. They all create the CAF or the cancer-associated fibrosis. And what I want to say in this scan is that the FAP is specific for fibrosis, arthritis, atherosclerosis, autoimmune disease, metabolic diseases, and cancer. So this is one pathway which is there in several of these tumors. And this is a diagram to show the interaction between endothelial cells, normal fibroblasts, the other connective tissues like adipocytes, the marrow cells, the progenitor cells and the tumor cells and interact, and they create this, this interaction creates these cancer-associated fibroblasts. So this is something like a person who is always present in most of these cancers. And gallium FAPI PET-CT, it's a molecule which is attached to gallium-68. It is complementary to tumor entities showing poor FDG uptake, that's because of poor GLUT expression. Example, hepatocellular carcinoma or pancreatic cancer. Also, high FAPI uptake is seen in esophageal cancer, non-small cell lung cancer, head neck cancer, and colonic cancer. FAP is overexpressed in cancer-associated fibroblasts and has limited expression in normal cell, and that is a big game changer. So, in PET-CT, the current standard of care, which is the FDG PET, the 18F FDG PET, fluorine 18 labeled deoxyglucose, has high uptake in brain, heart, liver, spleen, and gut, and it has done extremely well in most cancer situations, although it has limitations in gastric malignancies, peritoneal metastasis, mucinous adenocarcinomas, and also in clear cell carcinomas. Limitations therefore exist in some GI, GU, GY malignancies. However, what is important to know is that they have done very well in the last 20 years, and therefore they have been the basis of treatment, follow-up, treatment modification, and excellent staging tool, which has led to so much of stage migration in many situations. But when we take the new agent, the gallium FAPI PET, it has very limited uptake in brain, heart, spleen, liver, gut. So there is a modified biodistribution compared to that of FDG PET, and that gives excellent contrast, excellent inbuilt contrast. FAP is overexpressed in several abdominal and pelvic malignancies. It performs slightly better than FDG across all solid tumors, and therefore it has new application of characterization, staging, monitoring treatment. A very early and landmark paper published way back in 2018 on the comparison of FDG PET and gallium FAPI. Well, we can say that FAPI performs as well as good as FDG PET in several tumors, and in several tumors it performs superior to FDG PET. And if we, for understanding that, this bar diagram will be very useful because this is a way by which we have represented the SUV uptake in something like the red line shows the normal blood pool activity. And you will find almost all the tumors. We are starting from renal cell carcinoma to the cancer of unknown primary. And you will find that they all show significantly raised SUV in almost most of the tumors, and some of the tumors show almost 3 times more uptake compared to that equivalent of FDG, and therefore they are a straight winner. So hence the uptake is more, and the biodistribution is such that the normal biodistribution is very much restricted, and there is not much of normal uptake in large organs like brain or heart. I think straight away we have a winner, because it will automatically bring up the diagnostic supremacy. And this is an example to show. I want you to concentrate on difficult tumors like ovarian cancer, pancreatic cancer, medullary thyroid cancer. So where earlier the performance of FDG PET was not so great. Also the radiation burden to this patient is going to be almost 50% of that of F18 FDG PET. That's largely because we will be using gallium-68. However, that is changing, that now we have F18 labeled FAPI agents that's available in the last few months, and this is going to give the same opportunity to all the centers, whether they are close to a cyclotron or they are very far from a cyclotron, because we are going to have F18 labeled FAPI agents, and that's going to provide excellent distribution opportunity like that of FDG. So coming to the to relatively a smaller part of the discussion, gallium FAPI PET-CT in GI malignancies, I have just taken a few examples from our own experience. So this is a case of a signet cell carcinoma of the stomach, and what we are seeing here on the left side is the FDG PET. There is normal uptake in the brain, but the uptake in the primary tumor is very, very less. In fact, we are able to appreciate the CT findings rather than actually the uptake. In fact, the uptake is as much as the background and hardly any. But when you look at the FAPI PET, the uptake is significantly high, and therefore we are able to see the uptake in the primary disease and also in the locoregional disease. So that makes it a very, very significant advantage. We are able to see metastatic peritoneal deposits, although that has not shown in this particular case FAPI uptake. Now this is a case of mucinous adenocarcinoma, and here again we have very, very little uptake on the FDG PET, and the supraclavicular nodes also show very little uptake. But however, we will find excellent uptake in the case of the FAP, and the FAPI is showing very good uptake, and the supraclavicular nodes also are showing very good uptake. So this is a signet ring cell carcinoma of stomach. So all these groups, signet cell, mucinous adenocarcinoma, these had a very poor expression of GLUT in that. That's why FDG was not being used for them. In fact, many authors were of the opinion that we should be actually looking at thymidine kinase, and we should be using FLT rather than actually using FDG. And in fact, many histopathologists also believe in giving KX67 score for these. But all these have now changed, because now we have FAP, and FAPI will do very well, and it will surely replace FDG in this. In fact, FAPI PET has now given an opportunity to look at many of these tumors, both at tumor at staging and also at restaging. So this is another case of a signet ring cell carcinoma of the stomach, and FAPI uptake in soft tissue mass proximal to metastatic left supraclavicular region is that we just now saw. And this is a case of a carcinoma of the rectum, and normally one of the important problems in the post-treatment scenario, we have a fibrotic tissue, we do not know whether it is viable or not, and this is a case where equivocal uptake on the PET, but we are able to see excellent uptake on FAPI. The adenorectal soft tissue mass, and this is a case of a carcinoma head of pancreas. In the CECT, we find that there is a pancreatic head mass, suspicious liver lesions, and FAPI PET-CT shows FAPI uptake in the pancreatic mass. So if you look at the FAPI PET-CECT, we are able to appreciate it very well, both the liver lesion and also the primary uptake, and therefore this gives us an opportunity to do an assessment of the pancreas in one go. And this is a case of a periampullary ECA post-surgery, with there is a recurrence in the liver lesion, in which underwent actually treated earlier with an RFA, and there are also some new lesions coming up at the aortic cavity at the surgical staples, and also segment 7 lesion, which is the post-ablation region. And what we are able to see that that there is an excellent uptake on the soft tissue lesion around the surgical staples. So it solves the problem, and it gives you a total different perspective compared to that of the FDG PET. In the case of hepatocellular carcinoma and hepatic nodules, while FDG PET was really used desperately, but however it was never accepted because the uptake of FDG was inversely proportional to the differentiation. So a well differentiated tumor would hardly show any hepatic uptake in the HCC, and except in a few difficult situations or rare, that also by few surgical groups who would use FDG PET to look at the uptake in the HCC prior to major surgery like a liver transplant, to understand the biology, where they gave it FDG uptake was considered as a very important part of the bad biology or the bad prognostic indicator in that situation. But now this is a paper which has looked at the liver nodules and this HCC, and which shows that the uptake is directly proportional, or uptake is directly proportional to that of the animal. And unlike the FDG, there is no variability in the HCC with respect to that of the uptake of the FAPI. So this as a theranostic molecule will now give us a lot of opportunities to treat this patient during various phases of this disease. And the FAPI in a case of peritoneal metastasis and bone metastasis in another such case. Now an example, that was a small spectrum of GAE tumors we saw, and this is an example of a carcinoma right lung with brain metastasis, and lung is one region, lung, especially the non-small cell lung cancer, where the root expression is excellent, and therefore FDG PET CT has been playing a very important role in the assessment of lung lesions, CA lung. But how does this change with FAPI PET? So this is an example where I have taken a patient who had brain metastasis, and so this is the normal FDG PET, and there is significant brain uptake, and this is the primary uptake in the primary, and you see here that the brain lesion shows hardly any FDG uptake, and therefore it becomes a false negative. But on the FAPI, the uptake in the primary disease is significantly high, and the uptake was also seen in the brain lesion, and it is pretty good, and because of the absence of uptake in the normal parenchyma, the contrast is excellent. So it is already a far superior diagnostic tracer compared to that of FDG. So if you take, when we take theranostic as a concept, we diagnose, we are able to diagnose on an hybrid image. We are using several molecular agents, which could be biochemical agents, or it could be peptides, or it could be amines, and they are labeled with positron emitting isotopes like gallium-68 or F18, and therefore FAPI is an excellent diagnostic tool in a hybrid imaging mode. And this seems to be better than FDG in almost all the tumors, and in all the tumors, especially the solid tumors. So now, having diagnosed them, earlier the question which used to be asked in a scan reading room is, oh, we are seeing so much of uptake. Sometimes we used to use the word Dalmatian scan, the scan looks like a Dalmatian. But why can't we treat it immediately? And we say, no, FDG can only diagnose, we cannot treat. And now we have the concept of theranostic, and we have a theranostic pair, and the pair is the same FAPI is now labeled with a different type of isotope, and that isotope commonly is the lutetium isotope. So the therapeutic counterpart is lutetium DOTA FAPI, and this lutetium DOTA FAPI will go exactly to the same place where the gallium FAPI went, and because it is carrying an isotope uh, which has beta rays or alpha rays, and therefore it can give significant amount of radiation to those regions, and the radiant, what you can call as focal, regional or cellular level radiation will be a very good therapeutic modality. Now, talking about this DOTA-FAPI, it was seen that while we talk of gallium FAPI, here the retention of the product is not very important, because once we inject, within 60 minutes we anyway finish off the imaging, so the retention is not so important. But in therapy, we expect the molecule to stay in that region for a reasonable long time. Ideally, if you take a good agent which is getting internalized, like for example, iodine 131 is a very good theranostic tool. You can use iodine 131 in small quantities. You can use it for diagnosis. And when you use it in large quantities, that is therapeutic. But what happens in iodine 131 is when it's taken up by the thyroid follicular cells, it gets internalized, it gets organified, and therefore once it gets internalized, it stays there, and therefore the small amount of radiation but continuous over a long period of time gives huge amount of radiation, and therefore it's a very superior way of treatment. So retention within the tumor is an important thing, and we find at the present that the DOTA-FAPI retention is not very good. However, actually the whole story of FAPI in the clinical world is just the last 3-4 years, from 2018. And now we have a dimer. That means we have actually two molecules or two FAPI components as one single entity. And that has significantly improved the retention. And this landmark work has been done by a group from AIIMS, my colleague Dr. Bal. He has made a very big contribution. And this is, for example, a case of CA breast. Now you see bulk of the disease is in the marrow and in the bone. And this is picked up on the gallium DOTA-FAPI. It's a dimer FAPI. And the same, when it is being converted into a lutetium DOTA-FAPI, now what they are seeing is that the retention is not very good, but still there is good amount of retention till 24 hours, which will give a reasonable amount of radiation. But for example, this is the case of a thyroid cancer where the patient has multiple bone metastasis and marrow metastasis. And also there are some bone lesions which also show FDG, which means there are more differentiated and non-differentiated elements, some showing root expression, most of it showing sodium iodide sympater expression. But when this patient was scanned with DOTA-FAPI, and almost all the lesions show excellent DOTA-FAPI uptake. And when this patient was treated with the FAPI dimer isotope labeled with lutetium, you find here the retention is pretty long as 168 hours. And this is an excellent proof of the pudding to say that this is something which is going to be there, because this will give a large amount of radiation. So now we have the proof also, and now we possibly have a solution, which is the dimer FAPI, which is going to be available as the therapeutic option for FAPI. So now we have on the therapeutic side, we have lutetium, yttrium-90, actinium-225. Now lutetium has got a good penetration, but it has what we call a soft gamma, soft beta. So for example, it's very likely to prevent marrow damage, and also it's very likely to prevent the kidney damage because it will not get penetrated much. But yttrium-90 has got a very long penetration compared to that of lutetium, but its half-life is very less. So it irradiates, and that's why yttrium-90 was being used for tire agency. But actinium-225, it's an exclusive alpha emitter, and alpha emitters are known to be excellent. They give a lot of radiation, but since it is only for a very small distance, they spare, and this is why when you have a patient who has a lot of bone cortical disease, you can use actinium-225, as the marrow will be completely spared. I don't think there is any other treatment which can spare the marrow as much as 225 actinium can. And also we have rhenium and samarium. These agents have relatively longer half-life. The rhenium has a shorter half-life and samarium has a longer half-life. And these also are agents which have been now shown to be labeled with FAPI. So there are half a dozen of these isotopes and we can make the right choice depending on the situation, and we can treat the patient based on what we see as the uptake on the diagnostic scan. So a diagnostic FAPI and a therapeutic FAPI put together is going to open lots and lots of opportunities for all of us. So in theranostics, FAPI is a molecule which is going to, which is the most exciting molecule at the present moment, as a one-stop solution possibly for most of the tumors, especially the solid tumors. And it is going to be very, very interesting as the medical oncologist and nuclear physician are going to partner, and we are possibly going to sit together and identify what would the best protocols to have the least amount of toxicity and the best outcome in most solid tumors. With this, I would like to conclude my talk, and I thank sincerely the organizers of this conference to give an opportunity to talk about this wonderful molecule. Thank you very much.
There are no questions as such for this talk. Just one question from my side. Since you have been using FAPI extensively, what is your experience as far as GI malignancies are concerned? And particularly from the theranostic point of view, if at all we have to treat, then do we have to do both the scans, FDG as well as FAPI, or one scan would be enough if we have to go ahead with therapy?
Well, we have a small experience. I mean, I wouldn't say that experience is very large. Maybe we would have done a few dozen scans. But there is a publication which has looked at least the gastric tumors and also has looked at hepatocellular carcinomas. A lot of publications are coming from China. So as it stands, there is enough evidence to say that you can actually conveniently not do FDG and do FAPI straight away. You will get better diagnostic yield. And so far, if you look at it, there are some groups in the world who were using the existing FAPI, but they were labeling with actinium-225. You know, actinium-225 being alpha emitter, because the retention, as I told you, was not even more than 24 to 36 hours. They were managing with alpha. But now, with what the type of work which is published by Dr. Bal and a few of the international collaborators, the dimer approach seems to be very promising, and that surely seems to be increasing the retention fraction. If that is so, I think it will make a huge impact. And incidentally, if you see, gallium PSMA also has been used in hepatocellular carcinomas. People have shown diagnostic accuracy and a reasonable amount of retention, but however, there has been no publication of any dosimetry data of people using lutetium or actinium PSMA in hepatocellular carcinoma. So the theranostic approach in GI tumors across is very much restricted, other than the ones which we have on neuroendocrine tumors. So that's a huge opportunity available for us, and I think we should grab it, because anyway these patients do not have much of option otherwise also. So I think the respective IECs of the centers should encourage this type of work, and I hope we are also lucky to get some good international collaborators who can share these dimers, because these are all very, very, you know, I would say precious products, because they have huge potential, and obviously they would not like to share with so many groups, but I think that is one option which is available, and I'm sure that that will be entering clinical practice. So at the present moment, doctor, I would like to recommend that from a purely diagnostic point of view, I think for GI we should quietly shift to FAPI, and that is rather than doing FDG. That is my first recommendation. And second recommendation is, very soon, I am very confident within the next, maybe within another 12 months, we will have an excellent product which will be a theranostic product, that is the therapy equivalent, and there we should start identifying good groups on whom the standard of care has been already completed. We should take those patients and we should offer them the theranostic approach with FAPI. That's my view.
Thank you very much, sir. Thanks for the talk, and it was a wonderful summary of what you spoke. We have come to the end of the workshop. We thank all the speakers, all the attendees, both online and offline, and we thank the organizers. Sunrise Oncology, Institute of Pulmonology, as well as CRSF for organizing this workshop. Thank you very much, and I declare that the workshop is concluded. Thank you.